Okay. It unfortunately will be a little muffled. Excuse me. I'm going to try and. Wow, this is mask. It's all the formaldehyde and stuff that's in the mask. Oh my goodness. All right. Yeah. Good stuff, right?
Go outside and learn.
I know.
That would be fun.
All right, so before we start, let me do some housekeeping.
I'll just admit in, so.
Is everybody here?
There's a few.
Okay, let me just check.
Here, I know where they are.
Yeah.
Whoa.
I saw Brandon told me about it. Cruz, I saw.
She's right there. I'm good now.
Okay.
It's not me.
No, that's not. Donna is not here.
She's not here. Well, I mean, she's here, but she's not here yet.
Oh, she is here then?
Yeah, right.
Oh, okay. Okay. All right. Asia, some Asia.
11. I'll catch up.
Jamie Down, yes.
Yeah,
Gorgeous.
Got
hair done.
This is one.
Tierney's here. Reagan.
She had an emergency.
Okay. She's not here today.
She was, but she, yeah.
Hey, you want to just. And she's here. Portia, no, she was here.
She is here. She's with,
First up there.
Okay. Ashane. Linda, I saw Linda. Linda. Here. Angelina, just saw you. Felicia, yes. Rebecca Jackson. Rebecca. You're on the other side, aren't you?
I don't know who's all friends with her.
Shanice is here. Kirsten.
She commented.
That's why.
Oh, no, I ain't friends with her like that.
Oh, okay. Somebody said.
The one person that is.
Valencia, I saw Valencia. There she is.
One person that is what?
Jamaica, not here. I'm so used to seeing you in a pink sweater. You're throwing me off. Amelia. Laura is here. Claudia is here. Evelyn is here. Brittany. Oh, there she is. And Kaylin.
She's here.
Okay, all right, so. Hopefully, they need to come in.
Yeah, Kaylin did. I know Kaylin did.
No, but I'm talking about the others.
I have no idea.
Okay, all right, so we've only got 2 weeks left, right? 2, 3, something like that. Week 8. Next week in lab, I want to do like a HESI review, okay? And review obviously for week 9 exam as well. Week 9 exam will be on the Wednesday. It will be here in class. And like I said, it will be a paper one as a result of what we discussed last week. So that's the format of it. Now, there are going to be a lot of different areas on that week 9 exam. And I will go over that with you. It is going to be some cardiac. It's going to be some insulin. It's going to be maybe even certain questions that you may have even seen before regarding some endocrine. What else is going to be there off the top of my head? I did the exam last night. Couple of things to do with fluids and electrolytes. A lot of things related to this week's work as well. Some GI stuff, so there's a smattering of different things, but I will go over the exam with you, I promise you, before we actually take the exam. So I'll make sure we do that. I don't know if I'll have time today, but if I don't, we'll do it on Monday for sure, okay? So I'll make sure we go over that. And then, as I say, I do also want to do a HESI review for you as well, and go over questions, the questions that potentially you're going to get, and we will go over all of those pieces. So this week, we are looking at a few different topics. And by the way, because next week is only a few chapters, depending on what's going on, I may even be able to add in one of these next week and maybe do some review this week as well. You know what I'm saying? I may split this a little bit so that I can do some week 9 exam prep with you as well. That might work better. But seeing as though we talked a little bit about fluids and electrolytes on Monday, what I thought I'd do is just obviously go over that. And then certainly I want to do GI as well. So, turn to chapter 29. And I think most of you are here. This is trying to think how I can set this up so that maybe I'll put it there. Okay. That way I'm in the middle a little bit more. Chapter 29. All right. So we mentioned on Monday about isotonic fluids, hypertonic fluids, and hypotonic fluids, right? And what we're trying to do is we're trying to keep our osmolarity, meaning our blood osmolarity, which is the concentration of our blood, between 250 and 375. This one, it says normal, it's 290 and 310. So, you know, there's differences, but basically there's a certain range that we're trying to make sure that we keep our normal osmolarity at. I'll go by the book because, you know, just in case there's a question about osmolarity, that way you're not going to get confused. But between 290 and 310, okay, that's what we're looking for. Our body is always searching for that balance. When you give an isotonic fluid, that's something like normal saline, and you give it for lots of reasons. You can give it because the patient might be a bit dehydrated, but it could be that they need it, for instance, if you're going to give blood, you're only going to give normal saline. You're not going to use any other fluid, okay? I'm telling you that for a reason. If you give regular insulin, an IV of regular insulin, a drip, you're going to use normal saline. On the whole, you're not going to use anything else. And sometimes you might use dextrose to bring in some potassium to the body. But on the whole, it's going to be normal saline that you use, 0%, 0.9% normal saline, okay? That's what I just want you to know. On page 458, there's that little cheat sheet here where it shows hypertonic, isotonic, and hypotonic. And so what we talked about and what we looked at with different case studies a little bit is just, let's look at hypotonic solution. So that means it's going to be a fluid that's more concentrated, like your 3% saline or your dextrose or something of that nature. It's going to be a very concentrated fluid that you're going to utilize. And what you're actually going to do with that concentrated fluid, with a hypertonic fluid, is you're going to actually try and pull fluid from the cells into that hypertonic fluid, okay? So if you've got a very swollen, like cerebral edema or something like that is going on with the patient, then you want to shift the fluid from the cells into the tissue and into the bloodstream. And the only way you're going to do it is by using osmosis. So the body needs to go back to balance and shift to a isotonic situation again. And it's hard to explain, but if you imagine a lot of salt in the body, or a lot of something that is causing something that needs to become hypertonic. You're going to use that hypertonic solution, and so it's going to help to decrease the fluid in the cells and make it normal again. Does that make a little bit of sense? Just a tiny bit.
You said the hypotonic.
If it's a hypertonic solution, meaning it's a higher solution than what is in our blood.
Okay.
So because it's a higher solution, it's going to pull fluid to it from the cells. So if somebody's got cerebral edema, you want to reduce that cerebral edema by using a hypertonic solution and pulling it from the cells. That's what we're doing that way. Also you might use it in something like a patient who has what's called hyponatremia. Anybody know what that is? Low sodium, exactly. So if somebody's got really low sodium, you might need to use one of these hyperconcentrated sodiums to give them sodium back into the body. Okay, so that's what we would do. We would use something like that. All right, so I'm talking like a sodium that's really low, I'm talking like in the 120s, like a really, really low sodium, critical type of level is when you would use that, okay? And then the opposite occurs if you need a hypotonic solution. So this time the solution is lower than our blood osmolarity, okay? It's a lower solution. And this time what we're trying to do is the cells are all shrunk. So we're trying to pull that fluid into the cells and plump them up. That's what we're trying to do, doing the opposite thing. So if somebody is in DKA or HHS, like I mentioned the other day, both of which the patient is very dehydrated, then you're going to give them a fluid that's going to help plump up the cells. So it's a little bit confusing, but the more you're and there's different, obviously I know you've got different resources like Picmonics and things like that might be helpful to visualize those things for you. And I want to say, I think I put some in my my thing as well. Where is everybody? Because there's still some people missing and they're not going to be able to clock in.
Miss Fletcher.
Yes.
So hypo, the fluid is going inside the cell. Hyper is going outside the cell.
If it's a hypotonic solution, then yes, it's going to be going in towards the cell.
Okay.
That's it's saying right there. So let's see, a hypo, I know it's a little bit, yeah. If you look on page 458 at this tiny little red thing right here at the top, this little tiny depiction right here, it's moving fluid. If it's a hypotonic, it's moving fluid into the cell. If it's hypertonic, it's moving fluid out of the cell. The concern is when we move stuff into the cell, it can burst the cell. So with all of these things, whether you're doing a hypertonic solution or hypotonic solution, either or any solution really, this is why we do what? Our drug calculations, right? This is why we do mils per hour and drops per minute and all these things, and we don't just open that thing wide and we're like, yeah, let's give it in 15 minutes, a whole liter, because we have to monitor that patient and make sure we do it safely so that we're not causing harm, right? We don't want to burst the cells and cause the patient to go in a coma. That's not our intention. That's not what we're trying to do.
So isotonic is like normal?
Yes, so isotonic is the one that isn't really going to change the body state. Now, we might use saline, for instance, if somebody's coming and they're a little bit dehydrated, it's been hot outside and they've been running and they just need some fluids. We might do just normal saline, right? We don't have to go too crazy unless the sodium's really, really low. But yes, so generally speaking, you're going to use something like normal saline, isotonic, okay? So I just wanted you to be aware of that because it is a little confusing. And on page 458, there's a table that looks at different types of dehydration. So you can use, for instance, an isotonic solution, as you were saying just now, Valencia. You could use it for something like diarrhea or vomiting, like a child, if you need to give them fluids. Weren't you saying it to me? Was it Linda? I'm sorry, I couldn't tell with your mask. But yeah, if somebody's got some diarrhea or vomiting and they might need just some fluids, right? Yeah, you know, gravid emesis, something like that, then yeah, you might give that. If there's a lot of sodium loss, then let's see. Depending on what's going on, if the sodium loss is greater than the water loss, which results in a higher concentration of solute inside the cells, then you're going to pull that fluid out. And then the hypertonic is somebody who's really, really dehydrated. They've been out in the sun, they've been fixing roofs or something all day long, they've not drank anything, and their cells are really shrunk, and you need to pour fluid in it. So then you've got your hypotonic as well. Or rather, a hypertonic dehydration is what's happened when the patient goes out in the sun and they've become completely depleted of all volume and fluid. All right, crystalloids. Let's just have a quick look at crystalloids, by the way. Colloids. Crystalloids are known as normal saline and lactated ringers. So that's in that isotonic solution that we were talking about. Colloids, go down to page 459 for me. That is our stuff like albumin. And what colloids basically do is they're known as blood expanders. So if someone's in shock, we might give something like albumin, all right? So I want you to be aware of what a colloid is. There's many different types of colloids, but basically I just want you to be aware there's albumin, globulin, fibrinogen, but the biggest ones that I've seen really is albumin and maybe globulin, those two. They're expanders, volume expanders. So if someone's in shock or something like that, or burns, you will use a colloid, definitely, because they'll need that protein, that albumin. Okay. So that's just something to bear in mind. I just want you to be aware of the colloids. Okay. And it talks about what they are right there. But the big ones that I see being used is albumin. They're usually in a big glass bottle. They're always in glass, by the way, because you don't want it leaching out into the plastic. So be aware of that. Let's see. And it says here, colloids are used for shock and burns, which they are. And albumin is the one that I want you to be aware of. Okay. Blood products. Now, has anybody ever been involved in either having a blood transfusion or, yeah, okay.
Always me.
Always you, gosh. All right, so, you know, they're gonna check what your ABO is, right? They're gonna check what you're able to have, right? You need to give the most appropriate one. You can't give anything else, right? You don't want to cause your patient to go into hemolysis. That's one of the issues with it. But bear in mind, there's a difference between packed red blood cells, and I'm not right now going into how to give blood, but I do want you to be aware that when you give blood, there is a whole process to it. You normally have to check that blood with another person. You don't do it by yourself. There's a lot of different aspects to checking it, whether it's not just their ABO, but also whether they're rhesus negative and rhesus positive. You're checking their name band, you're checking who they are, you're checking that, you're checking the date, you're checking the expiration. There's a lot to it. to giving blood. And you're not going to give blood, usually over 4 hours is the maximum that you're going to give blood, okay? Maximum time. It normally is put on a pump
And that's per bag, right?
per bag.
That's what,
Correct.
because I had 3 bags.
Yeah.
It's like they definitely didn't get that.
Yeah. They gave each one usually.
Right, yeah, I was like,
About
they didn't
4.
get all 3 in.
No. And remember, you normally give it, the only fluid you normally give it with is saline, normal saline, 0% normal saline, isotonic fluid, okay? Not going to affect the blood because our blood is isotonic, all right? There is a difference between packed red blood cells, which is in your book on page 462. I want you to be aware of that, and whole blood. Whole blood is given if you're, again, if you need somebody that has to have volume, right? So if they're bleeding, if they're in shock, post-surgery, something like that, maybe you're going to give whole blood. But packed red blood cells are basically that. We're sort of reducing that volume, but we want to make sure that the patient gets all of the goodies that they need. So basically the oxygen capacity of that blood product is more intense for that patient. Does that make sense? Because it's just the hemoglobin and hematocrit, the red blood cells. The actual fluid is reduced. Now you're thinking, why would you think you would want to give somebody red blood cells, packed red blood cells, as opposed to whole blood? Any ideas? Yeah, more oxygen. Absolutely, that's a good one. Less volume on the heart. Yeah, I like that. Absolutely. What about your oncology patient who's having a lot of different blood products, right? They are constantly having blood products, whether it's platelets, whether it's packed red cells, whether it's fresh frozen plasma. So we don't want to overload those patients because more often than not, they're getting blood products nearly every single day. So that's another type of patient you want to bear that in mind. We want to give them the red blood cells. We want to give that hemoglobin and hematocrit and all of those pieces, but we don't want to fluid overload them. So that's another type of patient. Yeah, you know, you're leukemic or somebody who's had cancer and then neutropenic and all of their red cells, their white cells, everything is tanked. They're the type of patient that you're going to make sure you give those things to, right? So just bear that in mind. There's a difference between whole blood and packed red blood cells, okay? Let's see, what else? Fresh frozen plasma is another one as well. Again, it's just the plasma. And again, it's used for patients that may need that expansion, right? They're in shock. We want to give fresh frozen plasma. It works in that way. All right, let's look at a couple of electrolytes. Potassium. There's 4 main ones that I want to look at. Potassium. So what is hyperkalemia? Hyperkalemia. What would that be? High potassium, right? So what type of level would that be above what? Any idea? Yeah, good job. Good job. All right. And then hypokalemia.
Lower than 3
Yeah, below what?
3 grams.
Yeah, you got it. Okay. And as it says right here, you think about what it does in the body, it actually regulates the heartbeat. That's partly what potassium does. So any abnormality, either or, is going to be a problem, isn't it? Right? It could cause some EKG abnormalities either way. So we may notice that our patient may have AFib, or they may go into a lethal rhythm, which they potentially could do very easily, okay? All right, something I really need you to know on the top of page 463, highlight it, underline it, circle it. because it will be on an exam. Your next exam, in fact. Look at how quickly you can give. Oh, hang on a minute, I didn't realize she's. Jamila's there. Look how quickly you can give potassium. On the top of page 463. Any idea what it says? IV.
Faster than 10 MEQs per hour.
Exactly. Now, there is an exception for critically ill patients that are on monitor. Potentially you can do 20 MEQs. But generally speaking, it's going to be 10 MEQs per hour. So if I have a liter of fluid and that patient is getting 40 MEQs, I'm still going to do 10 MEQs per hour, right? 10 MEQs per hour. Always. So bear that in mind if you see a dosage count question or something like that. It may say the total volume, all right? But you need to know how many mils per hour I'm going to give if it's 10 MEQs per hour and say it's a 500 ml bag. Anyone want to have a go at doing that? You.
Whether,
50?
Well, look, think of it. So 500 mils, it's 500 mils, right? And we just said there's 40 MEQs in that 500 mils.
Okay.
So we know it can only do 10 MEQs per hour. So how fast is that fluid going to go? 125. Yeah.
Oh, okay.
Yeah, 500 divided by 4, right? Because we know it can only go over 4, it has to be over 4 hours. You've got 40 MEQs in there. Does that make sense? No? Yes. Get it?
You really said the 500, because at first I was confused.
Yeah, 500 mils. Right. All right. We also looked at if there's too much potassium, we're going to do what? K-exolate as a binder. Remember we talked about K-exolate, some of us? K-exolate we can give. The other thing I want you to be aware of as well is potassium burns. Very, very painful for the patient. You will never, ever, ever give IV potassium as a push. You will kill your patient. Okay, first of all, you're not going to do it that way. The patient can have oral potassium, but you do not push IV potassium. And as I say, potassium is given very slowly by a running line, and it still burns. Still very, very uncomfortable for the patient. Okay. So K-exolate, as I say, is what we use. Sometimes they give it orally, sometimes they give it down the NG tube. But basically it binds and it pulls potassium with it. It binds it and it helps to excrete that extra potassium. And that is on page 464. Okay. So bear that in mind. Let's see if there's anything else that I want to bring out of that. I would definitely have a look at that though. Sodium. All right, so hyponatremia is what? Okay, and what range would that be? Below what? Okay, and hypernatremia. You got it. You got it. All right. So let's look at what can happen with hyponatremia. Any situation where the patient is voiding too much. I actually had a patient yesterday, a young guy, I'm going to see, in his 30s, he's a waiter. And this is why I'm bringing this out. He's on an SSRI, which is what? Any idea what
Serotonin.
antidepressant, right? Serotonin, antidepressant. And he's been on it for years and years and years. And when I checked his sodium was a little on the low side. It was 133, which is, not that crazy. But I noticed it. I'm like, oh, that's low. That shouldn't be low. So what things do you think I might ask? He's a waiter,
I've got his diet.
right? Yeah. What about fluids?
Yeah, fluid intake.
Yeah, he drinks about 3 liters a day, so he drinks quite a lot of fluids, right? But look at this, what it says here. Hyponatremia, one of the things that can cause, a medication that can cause it, ding, 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 SSRIs. Yeah, SSRIs. Now, it's not causing him a lot of harm right now, but I do want you to be aware that these meds do have an effect on things, right? And of course, then there's other things like what's called syndrome of inappropriate ADH, which basically the patient will pee out liters and liters and liters of fluid. So just be aware of that. All right, and then hyponatremia. I really want you guys to look at the side effects of these things. Unfortunately, a lot of the side effects are sort of similar. Lethargy, headaches, all of those types of things can be similar. Seizures, but even so, I do want you to be aware of what those can look like. Thankfully, my patient didn't have any of those symptoms. He felt perfectly fine. But the SSRI can cause that. Okay. Again, we look at hypertonic saline, which is 3% saline, okay? We're going to give it very, 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 very slowly to the patient. It says here as well, if you give it too rapidly, you can have what's called osmotic demyelination syndrome. Brainstem damage can occur to that patient because of the osmotic pull if you give it too quickly. We can give sodium chloride tablets if we need to. We can get our patient to eat a diet that has a little bit more salt in it, right? If we need to as well. So our assessment, it's good to look at assessment, right? And see what's going on with our patient. What I want you to be aware of is this medication called Convivaptan. It's a vasopressin. It's actually used for patients that have low sodium. They'd have to have really, really low sodium to have that, by the way. Yeah, something like that. So the things I want you to be aware of are your lab values, which you've already you know them. I also want you to be aware of signs and symptoms for hypokalemia, hyperkalemia, hyponatremia. Be aware of what those things could potentially look like, okay? And be aware of some of the things, why the patient might end up having those situations. Are they dehydrated, for instance? Are they vomiting? Do they have diarrhea? Are they in shock? All of these types of things we need to look at. Let's see if there's anything else. Oh, the other thing on page 468, foods that are appropriate for your patients to know about with sodium, where in this case potassium. High potassium foods. There's a couple of them there, right? Like orange juice, apricots. We all know about bananas. It's on page 468. It just shows a couple of them. Okay, so again, it talks about potassium. IV is always given diluted. your patient will have a cardiac arrest if you just push potassium. Okay. Look at what it says as well about the urine output. How much do you need per hour for your good urine output? Well, for me,
30 or
30. Exactly, you got it. Mhm. And let's see. I think I'm beating a dead horse when I say don't give these meds, don't give these fluids too quickly, but it says it over and over and over again. So if it's saying it over and over and over again in this chapter, there's probably a good reason that it's saying that. Obviously, you need to know that, but potentially it could be on a test or something as well. So you will give these fluids slowly, okay? So it talks about the hypo, if somebody's got hyponatremia, meaning they've got low sodium, and we're giving high sodium fluids, you are gonna give that slowly, 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 slowly. Or you may cause basically brain death. Okay. And it talks about it right there as well. You know, when you're trying to adjust it either way with the fluid for the brain, either way, you can cause brain injury. Okay. We're talking about preventing fluid overload. How would you look for fluid overload? What types of things might the patient look like if they're overloaded with fluids? Swollen, edema, yeah, pitting edema. What about the lungs? Wheezing, crackles, those types of things, yeah, sound very wet. All right, let's see. Okay, blood. Down at the bottom here, how are you going to give your blood? Yes, you are going to use saline, but look at this. You're always checking your expiration. You're never going to give out-of-date blood, right? I think that goes without saying, but you're not going to give out-of-date blood. You're always going to check it with another nurse before you hang it. You're always going to check for the right cross-matching. And here's what I want you to look at. This is on your exam. It might be on the HACCP, but it's definitely going to be on your exam. On page 469, you need to know what a transfusion reaction would look like.
Where is that? Oh, okay.
know what a blood transfusion reaction is.
Correct. You need to know the signs and symptoms of a transfusion reaction. So what are we looking at here? On page 469, can anyone tell me? Some of them?
Oh, okay.
Yeah.
Fevers, chills, nausea, weakness, drowsiness.
Back pain is one of the classic signs. Restlessness. Yeah. There's a lot of different signs that sort of clue you in, and that's why we do vitals so much, right? On the patient that's getting blood, that's why in the first, I want to say the first hour, we do vitals every 15 minutes. Or we used to. I don't know if we still do, but yeah. So you've got to be checking that patient frequently because things can change really quickly. But joint or low back pain is a big one. Dyspnea, all of those, I need you to be aware of that. And look what it says. You're going to keep that line open with what? Isotonic.
Isotonic and solution infusing slower.
There you go. All right. And if they have a reaction, everything gets kept. Hey, where have you guys been?
We are caught in transit. So, Custom, Bullshit,
I'm done.
I'm sorry,
It
Lon.
was okay, I was trying to figure out.
I just checked in.
I used to be both.
This is the chapter I'm telling you about that I'm like, I can't not write
I
everything.
was seeing both.
I don't have that much. I like to say real quick, and I'll take my breath like that, but I have it. Yeah, there you go. Okay. All right. At the bottom of this little thing, there's a nice little case study, okay? Just talking about the patient having a IV infusion, which is just saline. But there's an issue with this, right? This patient has had, he's a little old guy, he's 85. Blood pressure is low. So they give him some fluids, but my goodness, what on earth? They gave him a whole 500 bag of fluid in 1 hour. Well, that's an issue, right? Way too much. For a little person like this little old guy, that really should have been probably about 100 cc's an hour. It says it should have been 100 cc's an hour. So we have a problem with this patient being overloaded, fluid overloaded. Just an example of that.
So what would you do in that case?
Well, you could diurese him. You could take some fluid off with something like Lasix. Obviously, if you're going to do things like monitoring him, you know, vital signs, put him on a monitor. Maybe put a Foley in to see what's going on there with his urine output. So, you know, checking his lung sounds, heart rate, all of those things. But definitely you're going to reduce that fluids. You know, you still might need some fluids, but you would reduce it probably to, they put it to 75 cc's now and they changed it for different reasons. But those are things you might do.
And would you record that as a medication error?
Yes, you would. Yeah, probably you would. All right. I would suggest on page 470, it talks about on this, I like these patient teaching center things. Here it says at the bottom, educate patients on foods high in potassium. Why am I bringing this out to you again and again and again? Because there are, I think even on the HESI, wasn't there a question about foods
It was
and,
about something, it was about.
Yeah. yeah.
Something about food, I think
Yeah,
the safety of it.
Yeah, but bear in mind, that's part of the teaching, and I want to say, I've seen a question like, should they have tomato, beans, and something as opposed to banana, kale, and whatever. So be aware of the foods that are high in potassium, okay? All right. Let's turn to, I want to say, she had a food page.
50, you said?
Yeah.
Oh, no, we'll do that, text them.
These are not tough, are they? These chapters are not as tough as some of the other chapters. Right?
I think we're just starting to get into a routine.
Yeah.
Brain's taking it.
Yeah.
Because the first couple weeks were rough.
You were like, I know. And the first week's chapters are easy chapters.
I know, but it's still coming in school.
Yeah. Now you know about me being a trumpet player, so even from an early age, I was like, I always felt sorry for my neighbors. I'd have my window open, practicing the trumpet, doing scales badly. Oh my gosh. But payback happened to me because I remember doing night shifts in nursing school. And one Sunday morning, I just got home from a night shift, like a 10-hour night shift. And the Salvation Army band, the Salvation Army brass band decided it would be a great idea on a Sunday morning to play near our nursing school, where a lot of us are trying to actually sleep. And I thought, it's just great music, but not when you're just on a night shift, you know. Anyway, all right. chapter 50.
Reflection. You got a dress on today.
I know.
I never seen you in a dress.
I'm not doing exercise today.
It was just whatever 29.
Oh, okay. Now,
You already know what she did in 49? We did over 29 before, haven't we?
Yeah, she did that.
Okay, so say I got highlights of 29 already.
So I'm down this end so I can see everybody a little bit more. All right, so let's go to chapter 50. We're going to talk about things like hydrochloric acid or the lack of it, stuff like that.
Can we take a break?
Yes, of
Right, break
course.
time.
Yeah, take a
Or we're gonna dive in and then.
Take a
I don't like this, I don't like nobody.
take a 10. And actually, first, I need to.
Why am I getting a break?
Just walk.
Did I get it back?
I bought 80.
Let's say 2%. Yeah.
Give me a minute. Rebecca.
That's 2%.
Yes. Did you do this? Jamie, I'm sorry, Jamie, I apologize. This one here, the dosage count. I'm looking at Jamie.
I need a charger for your, I like that thing.
Did you see how many we did? We did. Okay, so you didn't do it. All right. Want to get it done? Get it done.
It's easier to take a picture and look at the picture.
You can still play.
So I did.
That's when I started, but
And I didn't have to keep going back.
What if I had?
that is what I'm tired
Yeah, I thought you could do it, yeah. If you do it and send me this is what I want. An email, just showing me that you've done it with a picture. That way. Right, who else? So Rebecca, Shanice, you're.
now.
No, you don't do it.
Oh, I thought I got to but that didn't hurt.
Exam. Oh, you're doing it right now, all right. Is it?
Right.
You know, If I had a feeling about MRI, that mammogram, that, so they want me to do a biopsy with the MRI guided one, because it lit up.
Okay.
But, so if I was diagnosed with it, doesn't that knock out getting insurance? Because like, I'm fixing to go back to work while I get it, but.
No, in fact, right now is opening for the Obamacare. We're literally right now.
So I gotta go somewhere. So I'm scared to get that done and then get diagnosed with something and then.
Georgia. I don't know what the products are in Georgia, but the open enrollment is open. I know it is for St. Florida, I'm sure it is for Georgia too. I would enroll right now.
Because I put off the procedure because I don't want to make it like
Open enrollment opened up about a week ago, so
Okay,
get
thank
on
you.
it. Get your insurance. Yeah. Okay, so whoever hasn't done the HESI homework, get it done, where are we, Wednesday? Get it done for me by the end of this week. All right? And let me know that you've all done it, please. Just send me an email that says HESI homework done, or, because I can't, it's hard for me to keep track. This is how I keep track. But, there's a few of you that still haven't done it, so get it done by the end of this week. And that way, I will grade it for you. And Portia, where did Portia go? All right. But I'm letting you know next term, I don't think they're gonna be as,
Oh, yeah, no.
they are not gonna play.
Do you live here?
Actually,
That's what I was going to do here.
oh, what?
To clarify, don't throw me in there.
She sent out some skits. She's not in our life.
I can have a million pair of glasses and I promise you I won't know where it's at.
All right, so, we've got 2.5 hours, we've got plenty of time to do. You want about 5 more minute break? Pardon?
I'll say half the class is still out.
I think what I'll do before we go is I'm gonna get my week 9 exam and go through it a little bit with you guys. All right,
So that's what we're doing, the week 9 exam.
on paper.
But I mean, that's what we're going over today.
Yeah, I think I'll have time, because we're here till 3:30. I'm sorry?
I said, can you make it really easy since we're under so much stress with this?
I mean, it's fairly
Is it
easy.
gonna be just like the other ones?
Yeah.
On paper?
Yeah, it's just like the other ones, but on paper. Okay. All right, guys, let's get cracking, because as I say, what I want to do, thinking about it, if I've got a bit of time, I want to go over the week 9 exam with you, and I think I might have a chance to do that if I get these chapters done, so we'll see. All right, let's turn to page 783, and the reason I want you to just look at it is because it gives an example of the stomach and what's going on in there. And we've got different things. We've got hydrochloric acid, which we actually need. And it says it right here, hydrochloric acid is a barrier to infection. Bear that in mind. That's going to become important when I talk a bit later. Things like intrinsic factor If you don't have it, you can't absorb vitamin B12, and you have to have exogenous B12. That's another thing. Prostaglandins. Prostaglandins have a lot of, they reduce inflammation and they're very protective. So there's different things that are going on in the abdomen, in the stomach, that are important, as well as things like pepsinogen as an enzyme to digest, all right? So looking down here, we look at things like what occurs when we've got too much acid going on. So we get things like peptic ulcer disease, which can lead, unfortunately, to things like esophageal cancer. You get that reflux going on. They can get what's called Barrett's esophagitis, and it can lead, as I say, to something called esophageal cancer. And you'll actually do a little bit more about that when you go into 1640, by the way. We often say about GERD, right? GERD is gastroesophageal reflux disease that occurs for lots of people. Pregnant women tend to get it. Tend to get it, right? Because of the situation right there. The abdomen's higher up. Obviously, obesity, it can occur there as well. And some people just have a natural propensity to it. Hydrochloric acid. We want hydrochloric acid in our stomach. We want that. It's actually necessary, like it says, it's a barrier to infection. The problem is when you get too much of it. And things that can cause a stimulation of that are a lot of our favorite stuff, right? Chocolate, coffee, things, caffeine, alcohol, different foods, yeah, all of the stuff. And look at what else can cause it. All of the things that you guys are going under, right? Emotional stress. Yeah. So you probably all need a PPI right now. So what are we going to do? What are we going to try and do with this peptic ulcer disease that is going on? Well, one of the things I just want you to be aware of on page 784, before we even get into that, is look at the top here, the different ways that hydrochloric acid is stimulated. Lots of different ways, either through gastrin, through the circulation, acetylcholine through the vagus nerve, which is that, you know, fight or flight type of thing, and also histamine as well, which is why we use these what are called H2 blockers, like the Zantac, which I think has been taken off the market now. I think it was. I think there's a rationale behind it that there was a risk for cancer. I'm not sure if it really got taken off, but there was some.
It did. I was on it 300 milligrams a day.
Yeah, there was some recall with it. So
Said it had too much MDMA.
Yes.
The MDMA causes cancer.
No. So we look at these different things, acetylcholine, histamine, and gastrin. And basically they help to secrete hydrochloric acid. So if one of those three messengers are not working properly, we might use something to block them so that they're not going to be able to upregulate the hydrochloric acid, right? So we're looking at peptic ulcer disease when you've got too much hydrochloric acid on board. And that's going to be either for the gastric ulcers, which if you look at your stomach is in the gastric area, or the duodenal ulcer, which is a little bit further down. One of the things we also found that the peptic ulcer disease is related to is what? It's not necessarily just hydrochloric acid, it's a bug, isn't it? The H. pylori bug is what they found. It's a gram-negative bacterium. And they're like, oh my gosh, this is what happens with 90% of the people with duodenal ulcers and also gastric ulcers, secondary to this H. pylori bug. And one of the things that we actually do is if somebody does what's called a breath test. Does anybody ever have to do an H. pylori breath test? You have?
Yeah.
Do you know why they did that? What were they looking for?
Is it like a sweet? I don't remember exactly. Is it-
Right.
is it
Yeah.
like a-
So you do a breath test, but what they're actually doing is these bugs, all the excretion from that bugs is going to be in that breath test. So if there is an upregulation of that in there, then you are positive for H. pylori. Did they put you on a combination of different medications?
Yeah, it ended up being negative.
Yours was negative, okay? But that's what they were looking for, the H. pylori bug. So you just had reflux for other reasons, right? Or peptic ulcer, possible peptic ulcer disease. But, so what they do, and the reason I want you to know this, as I say, because it's important, because it might be on an exam question, is if somebody is positive for H. pylori, they've done the breath test, they're positive for H, they've got an ulcer, it turns out it's positive for H. pylori, they're going to put them on a few different things. They're going to put them on what's called a proton pump inhibitor. That's your omeprazolone, all right, something of that. Like, they're also going to put them on an antibiotic. There were probably a combination of antibiotics, actually, usually 2. They'll put them on something like amoxicillin, but they're also going to put them definitely on metronidazole. Definitely on metronidazole. So there's a combination of things that they may put that patient on for a couple of weeks to help get rid of that bug first. Okay? So let's look at some of these things that we can use to help control acid. There's certainly things like antacids, over-the-counter antacids. And on page 789, there's a whole slew of different antacids, different types of antacids. So we've got the ones like magnesium, like Gaviscon, or milk of magnesia. We've got some that contain things like, and I'm going to say, I can't, you say aluminium, don't you? No. You say aluminum?
Aluminum.
Aluminum, yeah, I say aluminium. I'm sorry. Yeah. So, aluminum. I have to always think about that because I say it differently. I say aluminium. Yeah. Yeah. I always have to think about it because I say it differently. You won't forget it. All right, so you're looking at things like amphigel, things like that. Aluminium, I'm going to say aluminium because it just is what it is. But aluminum containing antacids. Then you've got some that contain calcium, like Tums. And we can give those ones, by the way, if our patient has osteoporosis. Oh, I'm sorry.
The top.
At the top.
We just can't find where you are.
Oh, there's a little box on 786. There's a box 50.2.
Okay.
Between that one and across from there it says selected antacid drugs. But I'm just giving you an idea that there are a lot of different types of over-the-counter antacids. And basically what they're going to do, regardless of the type, is they're going to neutralize that hydrochloric acid. That's what they're going to do. But bear in mind, they can, people take antacids, again, it's like the whole ibuprofen thing. It's over the counter, so it must be safe, right? So they'll take a lot of it. And that can be, unfortunately, because what happens then is they can actually become alkaline. And that can be a problem too. We don't want somebody to be too alkaline or too acidic. And it just mentions that as well, that they can get what's called milk alkali syndrome. And just bear in mind what that's going to look like, signs and symptoms of that, things like headaches, nausea, hypercalcemia. Okay. So we're looking at these over-the-counter types of antacids. Magnesium ones, they're going to have a laxative effect. So your patient might need to know that. That might be a good thing. They're constipated. And sometimes we get that, right? So then we look at our H2 blockers. Remember, histamine is one of the issues. Over expression of the histamine can cause too much hydrochloric acid. So we look at these H2 blockers, which most of them are over the counter now as well. They actually inhibit a lot of hydrochloric acid. But we do know now with ranitidine, and also I think famotidine as well, Pepsid, there is a cancer risk with them. As you say, it was the MDNA, wasn't it?
Yeah.
It was taken off the market.
That's what they were saying.
Yeah, MDNA. So just to let you see what types there are on 788, you've got your Tagamet, your Pepsid, and your Zantac. There's also, cimetidine. Cimetidine is still around. And I think Pepsid is still around, I think.
It is.
Yeah. But Zantac is the one I think they took off the market. So what does that leave us? That leaves us good old what are called PPIs, or proton pump inhibitors, which is the ones that we tend to use more of now. And if you look on page 789, they all end in, it makes it really easy, Razole. So if you see a med with Razole at the end, it's probably a PPI. On page 789, right at the top there, it gives you the list of all of them. Lansoprazole, Omeprazole, Rapiprazole, Pantoprazole, Esomeprazole, on and on and on. They all end in prazole. Do you see that? So that might help you remember what they are. All right, so these things are great if you've got GERD. They block 90% of hydrochloric acid, which is not a bad thing if that's what you're trying to do. But bear in mind, this is why I said right at the beginning, what does hydrochloric acid do? It prevents what? Infection. So this is one of the reasons you don't want this patient on this for a long time. People want to get on this and then they don't realize that you actually only want them on it for like 6 to 8 weeks maximum. And usually it's a once a day dosing, okay? So that's the problem with this. You don't really want to block hydrochloric acid for long. There's a lot of issues with that. And one of the big issues, as it says right here, hydrochloria can cause complications such as bacterial overgrowth, or SIBO, small intestine bacterial overgrowth, which I've seen a few people with that. And the other thing is a big issue is hip fracture, okay? It can cause osteoporosis. Yeah. So that's a big issue. Our little old people running, or not running around necessarily, on their walker, right, with a PPI, we think we're doing a service by doing that, and lo and behold, they fall over and end up with a hip fracture. Part of the problem is because maybe they're on a PPI. See? Yeah, she's giving you cheers. I saw that. It looks like you guys are drinking big tankards. Like cheers. You're like at a German beer festival or something.
I wish.
That would make farm fun, wouldn't it? Right. So anyway, bear that in mind. So PPIs, they're the first line therapy for GERD. That's what we do. We also want to be aware of, remember some of these meds get given down a tube, an NG tube. So please be aware that although they are in granules, PPIs can be in granules with an NG tube, they can clog the tube. All right, so you've always got to be careful of that. Remember with your nasogastric tubes, I think we talked about that, making sure that you don't clog your tube up. All right. Anyway, PPIs can cause things like C. diff, Remember what I just said? You can have an issue with bacterial overgrowth in the gut, right? Because you don't have that hydrochloric acid there. So things like that, osteoporosis is another big one as well, and pneumonia as well. So Prilosec or omeprazole, that's a prazole, so we know it's a PPI, right? Protonix or pantoprazole is another one. And all of these basically 4 to 8 weeks max. Probably going to be an exam question.
So if you take that for like years, like 10
Not a
plus
good
years,
idea.
it's not good.
No. Am I speaking to you, Selena?
Yes, I have mine's caused from a hernia.
Mm-hmm.
So if I don't take it, I can't even swallow it.
Yeah. They don't want to fix a hernia?
They haven't never even tried. They just keep giving it to me, and I've been taking it since like 2000.
See, this is where, this is the type of thinking I do. I'm like, let's fix the root cause. I mean, that would make more sense. All right, anyway, moving on. A couple of other meds that I want you to bear in mind, and one of them is definitely on a HESI. It will be on the HESI. Sucralfate. Sucralfate is just basically, this one is not. We don't use it a lot. Sucralfate is a big pill, and you can actually make it into what's called a slurry. But sucralfate is just like a coating. It coats the internal area in the gut. All right. But we do use it. They call it like a mucosal band-aid because that's basically what it does. It causes a nice coating on the gut. But the one I want you to be aware of is this one here, misoprostol. And I know you're all frustrated because it came up on your HESI, right? Misoprostol.
Pretty sure it is.
Oh, yeah. And it will probably come up on your final. It will come up on your final.
I didn't get it on mine.
I remember seeing it.
I see something about peptic ulcer on my head.
No.
It was asking about the rating scale.
Yeah.
It was asking about that particular drug, but, so what does the rating scale have to do with peptic ulcer?
Well, that I don't know because I don't know the whole combination of the question. But if somebody, the rating scale is to do with pressure ulcers.
Yeah,
that's what it was.
Yeah, it was saying about
I didn't
liquid.
understand it, I never went with a rating scale, so I wasn't sure.
Yeah,
It's like
I
a
think
liquid in your body.
I think I
or
put
something,
power.
pressure.
But it was peptic ulcers. It was something about ulcers and positioning and stuff like that.
Yeah,
But what was the question?
I don't
It was like,
remember, but I know the
rating
answer
scale,
was
yes.
about urine,
Yeah.
like having too
about
much
the
in your
urine output.
body.
It was
rating
about a
scale.
pressure
So I know
ulcer.
that urine is like 30 milliliters per hour.
Pressure
Right?
ulcer,
It's
totally
two
different
different
thing.
type of,
Let me
it's,
carry
yeah,
on. Let me
it's
carry on.
totally different. They're talking about a pressure ulcer, not a peptic.
Okay,
They're
thank
talking
you.
about a wound, the test, what we had today was a wound.
I just asked to say ulcer, so I thought it was the same thing.
Yeah.
No.
It's two different.
Okay.
Oh, okay.
All right, let me talk about this medication, right? So this medication called misoprostol, it will be on the HESI. I can promise you. Why didn't you get us all one? Yeah, you didn't tell us you were doing a Starbucks run. Next time I'll have an Earl Grey with almond milk. No. All right. Misoprostol is a prostaglandin. So remember earlier we talked about prostaglandins being protective. Right at the beginning, remember I said your body needs certain things in your gut, and prostaglandins, it was way back here, but they have protective and anti-inflammatory effect. Are you asking where I'm looking at?
Yeah.
Okay, I'm sorry. I'm on page 790, right down the bottom.
Bottom right.
The drug is called misoprostol, and you need to know about it for your HESI.
I'm
So
gonna just remember both of them, because sometimes they have the other name, and it'd be confusing me.
Cytotec, know both of
Yeah,
them.
I've seen a few like that.
Yeah, they had the other names, I'm gonna just remember both.
But prostaglandins have an anti-inflammatory effect, okay? But bear in mind,
I'm sorry. Is it an NSAID,
it's actually saying it reduces ulcers in patients that take NSAIDs, okay? But here's the problem with this drug. Look at the other issue with it. It's actually used as an abortive medication as well.
So, for babies.
Yes. Mr. Pro, and that's
That's what was on the Heston.
exactly.
Do not take it.
So who do you think is, so who do you think is contraindicated for?
Pregnant women.
So maybe the question was that, when it talked about pregnant women, it was talking about this medication.
I don't remember that.
Yeah, I did too.
All right. Simethicone is one more. This particular med really is good for gas. It's an anti-flatulent, okay? So let's think about this as well. This is patient teaching. What types of things, what types of foods can potentially cause gas? Thank you. All right.
And coffee, and food, and cheese,
I wish I'd asked. I shouldn't have asked. I should have just moved on. All right, anyway, that's a good one. But also different things like cauliflower, broccoli, all of those types of foods, all right? So just be aware, you know, if your patient has gas, you might want to do a bit of patient teaching. Don't eat those types of foods, yeah?
Take Dino.
Take Dino, exactly. All right.
That's for the other medicine stuff.
So just bear in mind some of the things we talked about. We want to make sure, as I say, that while we're doing the right thing by giving these patients these PPIs, that they understand the risks of PPIs, like I've just talked about. If you end up, if somebody is ending up on misoprostol, then please make sure they are not pregnant, okay? On page 793, this section of patient-centered care, patient teaching are the biggies. Things that you might need to know as well. Yeah, aren't they better?
Yeah.
I wish all the chapters were like this. I know. Really, I think they should break these chapters up.
They should.
And honestly, I think farm should be taught.
In every term, right?
It is.
I really do.
That's how most schools do it, though. Most schools integrated.
No, I think that. I
Most
do.
schools integrated in every
Yeah.
term instead of having to do one term.
Yeah, it's a lot. It's a lot.
It is.
All right, a few things I want you to bear in mind on some of these patients as well. Make sure they take the PPIs in the morning before meals. It's in the patient teaching section on page 793. Okay. Yeah, and remember what I said with the H. pylori infection, they're usually given a PPI, metronidazole, because it's that sort of flagellated type of bug, spirocheted bug, and also something like amoxicillin. They normally have a combination of about 3 different meds that they're taking for about 14 days. Okay. All right. Let's see. We've only got a couple more questions, and then as chapters, and then I would like to do some exam prep work. So, bowel disorders. Bowel disorders.
What's up, very good?
So we're looking at anti-diarrheal meds on page 797. Medications to help with diarrhea. So there's different groups. There's the adsorbents, which literally do that. They absorb, right? We've got ones called anti-motility drugs. So that's things like your anticholinergics. Remember, cholinergics are your sludgy ones. Anticholinergics dry everything up, right? So that makes sense that we would give an anticholinergic. Makes sense? Yeah. We've got opiates as well because they slow gut motility down. They can cause constipation, so that's a good one if you've got diarrhea.
Which one?
And probiotics. So we have a few different ones. And at the bottom of page 797, there's just a little cheat sheet there, table 51.1, that just talks about the different types: adsorbents, anticholinergics, opioids, and probiotics.
So Ms. Fletcher, I
Yes.
have a question.
Yes.
We can make this. It seems like all the drug classes are used for different parts. It seems like it's the same drug, like anti-chlorogenic, right? So it seems that it's the same drug that's being used depending on the diagnosis. So, right? So how do you, once you get one understanding of the drug, right? How do you apply that to different classes? How do you know the difference in the class, like the anti-chlorogenics are also in the bowel? So how would you begin to understand how it's being used in different parts of the body? I think that's what's stopping me. Like, I understand the drug, but then when I study, I'm studying it for that particular system. So then now, once I get these anti-chlorogenics from the bowel, is the same exact side effect regardless of where it's being used?
Yes.
That's my question.
Yes.
Okay.
Yes.
Everything's.
So it's still trying
So
out, regardless of which
It's
body
going to
system
dry
it's
you
used.
out.
Okay.
So, and it still can cause constriction. So somebody with glaucoma, potentially, that, you've still got to bear that in mind, and that's what you're absolutely right. So, yes, that's like a lot of these meds, right? Like an eye drop. Remember some of the eye drops that work like a beta blocker?
Yeah.
That's why you have to do this, so it doesn't go systemically and cause their pulse to drop. Does that make sense?
Got you. So I think that's the confusing part we were having on the head. We were studying the drug for one the body system and just, I think, trying to apply it to that system. So when you just said that, now I'm like, oh, so you saying drugs are also.
So once you know what a
used in
beta
bowel
blocker
disorder.
do, that's what a beta blocker do
It
regardless.
doesn't change regardless of the body system is the question.
Correct.
It doesn't. Got you. I was saying it
Side effects are gonna
changed.
be the same, but here's the key. Opioids cause constipation, right? Opioids slow the gut down.
Got you.
So if somebody's got diarrhea, maybe you could give an opioid because it's gonna do,
Oh, okay.
Got you.
that. right? So, all right, all right.
Go home, I'm about to go home. Please.
COVID-19?
Get a tissue.
All right. All right, so let's go through this because I really want to get this done so that we can do some exam prep, all right? So let's just look at some of these ones. One of this one that I really want you to be aware of, this one, it's called bismuth subsalicate. Subsalicate, what does that sound like? Salicate is aspirin, right? It's got aspirin in it.
You know that.
Got aspirin in it. So who would you not give this to? Thank you.
Is that Pepto?
Hmm?
Is that what's in?
Or anybody that has
Bismuth.
hepatotoxicity.
I was gonna say,
Is that what they call it? If you have hepatotoxicity, that would
Possibly,
be
yes.
aspirin, right?
But here's what I want you to be aware of this particular drug. I'm sorry, it's page on 798 is where I am. It's an antidiarrheal. I think it's over the counter. Bismuth subsalicate. The thing is with this drug and medication, when they take it, it'll actually darken the mucosa. It might give you a black tongue. So you need to let your patient know that, right? It's not going to harm them, but you know, they need to be aware of that. Also the stool as well might be dark. So they may have dark stools and think they're bleeding when in fact they're not. So that's something that you need to be aware of. All right, let's see, belladonna. We sometimes, Donatella is one, but look at what we're saying about this. What does it do? It's an anticholinergic, so it's going to cause constriction. So those patients that have glaucoma, you may not want to give it to them, right? Okay.
Got you. So even though the same drug, that's working on a different body system, it still holds the same effect.
Right.
So the contradictions will still be the same depending on the disorder, right?
Right. And look at what this drug, this anticholinergic does. First of all, we use it like the scopolamine patch, right? Scopolamine patches dry everything out. Atropine dries everything out. That's what this does, belladonna. I don't think we use it that much, honestly. I don't know if we use it that much. Donatella, I've not seen it, but it might be for somebody who's got really acute diarrhea. I'm not sure. I've not seen it used. Opioids. Now bear in mind, some medications for diarrhea may just have a diarrhea type of medication, but they may have an opioid along with it, like Lomotil, right? Lomotil rather. So, or loperamide. So bear in mind that some of these have opioids in it. I don't know if Imodium does. Let me just check for you. Don't think Imodium does not. Oh yeah, it does. I'm sorry. Yeah, Imodium does. Yeah, Imodium does. A synthetic.
Oh, yeah.
Yeah.
Isn't that a laxative?
No, it's the opposite.
It's the opposite. So basically, loperamide and Lomotil works like an opiate. It's synthetic, but it still works like an opioid. So the concern is, hey ladies, the concern is with these meds is they can be abused, right? Because they're still going to work like an opiate.
It's pretty crazy. So they could be an addict for opiates and go get it at the store. And
Possibly. Yeah.
That's crazy.
It's a synthetic opioid agonist, so it upregulates the opioid receptor effect. All right. So the other one I want you to be aware of is probiotics as well. And the one that is a prescription one is Florastor, which you may have seen in the hospitals, Florastor being used. Maybe give it down the peg tube and things like that, Florastor. Okay. But basically what probiotics do is reestablish the normal gut flora. So we always want to go with something like that. All right, so just bear in mind pediatrics, what types of things we do for pediatrics. Obviously, we want to be cautious with our antidiarrheal medications for our peds patients, okay? We want to check them really carefully, make sure they're not getting dehydrated because they can get dehydrated in a minute.
On which page, I'm sorry, which one? On the laxative you said?
On page 799, the considerations for your pediatrics.
Lifespan of pediatrics.
And bear in mind that people, especially adolescents, right, take laxatives because they may have bulimia, they may have things like anorexia, things like that. So be aware of abuse of laxatives for definitely people like adolescents. Okay, laxatives, which is what we're going to talk about now. So again, we have different types of laxatives. We have bulk forming laxatives like Metamucil. We have lubricants like stool softeners. We have hyperosmotic ones, and basically they increase water. Remember what we said, osmosis? So if you've got something that's a got a lot of concentration to it, it's going to pull water to it, right? That's your hyperosmotic one. You've got your laxatives that increase osmotic pressure in the small bowel. Again, increasing water. That's your things that are used for Go Lightly prep. That's your prep for colonoscopy. Okay. And then what else do we have? A stimulant like senna. Naltrexone is one as well. And I'm sorry, and then finally naltrexone as well. We use naltrexone. Remember Narcan? Narcan? What is Narcan?
It's the antidote for
Right.
opioids.
So, to my point, it's the antidote for opioids. What do opioids do?
They long slow.
Yes, but regarding the bowel, what do opioids do? Constipate. So, the antidote, the opposite, is naltrexone, right? Yeah, Narcan.
When you put it like that.
I know,
Which
yeah.
page is that? Is that on the second page?
801,
I don't see it.
Top right.
top right. But that could be for somebody who's had, say, surgery, bowel surgery, and their gut is really slow because of the opioids, so they may give naltrexone to help.
You said it's called albamopan?
No, naltrexone. Methyl naltrexone.
Oh, I got you.
Yeah.
But it said it's only approved.
Because it's the opposite, right? It's the opioid antagonist. Does that make sense?
But it's only if you're in hospice, right? Or have constipation through opioid. For that particular drug.
For this particular drug.
It says it's approved only for hospice patients. So is that only for the hospice patients who have opioid-induced constipation?
Probably, right.
What's the
But
reason?
only for hospice patients, right?
Only people
That's
that.
my concern. This is a book that only
Because
hospice.
they're on really strong
They
medication.
are on
Right.
strong narcotics.
Regardless who they are.
Long-term.
Whether you're hospice or not.
I don't think you'd be on that show unless you were in
No,
hospital.
I'm just saying, this is a book says, we're trying to make sure that, is this for hospice patients?
That's
or-
what it says, so I would go with that.
Got you, okay.
Now, maybe off-label it gets used for other things, but I
Yeah.
would use that. All right. But it does say, so right down at the bottom here, we've got table 51.4 that just shows you the different types of laxatives that I just mentioned to you. Okay. Adverse effect, one of them, of course, electrolyte imbalance. Another one, of course, is abuse. Elderly tend to abuse laxatives as well, don't they? Yeah. So with our bulk forming ones, basically what it does, it helps to create bulk in the rectum, and that is a stimulus to help to help have a bowel movement. So that's one of the reasons the Metamucil, those types of things work. Okay. And then of course we've got Ducosate or Colase. That just is a stool softener. And then our hyperosmotic laxatives. That's your, as I say, your Go Lightly Prep, polyethylene glycol. That's fun. Lactulose. This is one that might be on the HESI. I think it's on one of your exams. Lactulose. Now, bear in mind, lactulose isn't absorbed, but it's going to pull fluid with it. It's also for your patient who has liver disease, it's going to pull ammonia with it. So a patient may not have an issue regarding constipation, but he may have liver disease, and it will reduce ammonia. So you may see your patient with cirrhosis. Has anybody ever seen them? To me, they look like a big bird. You know, they've normally got tiny little legs. I mean, you know, big tongue. I mean, they do look like big bird. Yeah. You know what I'm saying? So, is that Sesame Street? Okay, see, I think I remember seeing it a million years ago when I was still in England. Anyway, so you've got the tiny little legs and the big tummy and all the rest of it, yeah? From cirrhosis of the liver. So that is always my depiction of what I think of when I see that. So, but anyway, if a patient is on lactulose and they don't have issues with constipation, it could be that they need their ammonia reducing, and that's what it does. it'll actually bind and pull it out of the body, okay? So as it says here, it's used for patients at the top of 804. It's used for patients with hepatic encephalopathy. So liver issues. And then of course our Go Lightly prep, which is bowel prep. One of the things to remember, that's going to clear out the whole bowel. Okay. Normally you make sure the patient has it with lots of fluids, like a Gatorade, that type of thing. Let's see what else I want to. And then you've got things like magnesium, saline laxatives as well, can also be used. Because again, saline is going to pull water, right? Salt, high concentration, so that would pull water as well. And just, I'm not sure if any, I don't know if there's going to be any questions regarding irritable bowel syndrome. The problem is with irritable bowel syndrome, it can go either way. You know, sometimes they have constipation, sometimes they have diarrhea. So it can be very difficult for the patient and difficult to manage. So it does say that there's a few medications. One of the medications right here is a SSRI. It's an SSRA antagonist, actually. So it upregulates serotonin, or rather, I apologize, it blocks serotonin. It's an antagonist. It blocks serotonin. It's called alosetron. Where's serotonin made, by the way? It is. It is.
What's the, you say serotonin? That's not serum. That's totally different, right?
Serotonin, 5-HTP. 5-HTP downstreams to serotonin. Why do I care about that? Yeah, so let me help you understand something here. People that are depressed or have depression, a lot of the time they have gut issues. That makes sense, because if serotonin is made in the gut, and they have gut issues on some level.
You don't give them the serotonin?
No, they're not able to produce serotonin, and serotonin is your happy neurotransmitter. What do we give patients for depression? We give them what? SSRIs, right? Serotonin, selective serotonin reuptake inhibitors. We give them something to help upregulate serotonin.
It's made in good. Okay.
Making sense, yeah?
Making sense.
So a lot of people that have gut issues have difficulties with depression because they don't have the ability to make as much serotonin as they need. So something to bear in mind. So if you heal their gut, then maybe you can heal other things too. All right, so I just wanted you to be aware of that. All right, assessment of your patient, again, you're going to listen to their bowel sounds, right? Listening to their bowel sounds, auscultation of the bowel sounds. You done that in class? A little bit? No? I don't know what you're doing tomorrow. I'm not sure what the plan is yet. Well, but no, I don't know if you're having class.
What?
Or no, I don't know.
We're supposed to get so much of a lecture. They did say they were gonna do
Lecture.
a few hours of lecture.
Yeah, 'cause I
For
think
fun.
yeah. Okay.
So we hope.
Okay. So remember, you've got hypoactive and hyperactive bowel sounds. Okay. Okay. And again, just be aware of your patients that have different diseases like IBS or Crohn's disease, because depending on what you're giving these patients, you know, they're at higher risk for things like perforation, all right, constipation, ulcers. So we do need to have an awareness of listening to their gut, looking at the patient. Okay. On page 807, I want you to be aware of how do you give a suppository or an animal? How do you give it? Any idea?
Rectal, you talking about like in your rectum?
Yeah.
You would have a patient lie on the side, right?
Which side?
I just know side.
Left side, always.
Left side.
Always. Any rectal exam, any laxatives, any, anything that you're going to do with the rectum, bowel, you put them on the left side. I think it's the way the bowel is. You don't want to perforate the bowel. So you always lay them on the left side to minimize perforation. Okay?
Would it be the same if they have like a rectal tube? Would it matter?
Well, that's a very good point, but I don't think the rectal tube goes, I'm not sure. I think the rectal tube is more on the outside, isn't it?
We just did a laxative.
It's in, but I would put it, when you put that thing in, I would put it in on the left side. I would always put them on the left. Yeah. So, but that's a great point. Bear in mind as well, probiotics don't just come in, pill, right? You can look at things like kefir, yogurt, kimchi, any fermented food, kombucha, fermented things. Okay. Patient teaching, again, be aware of them understanding that it's not just about taking a laxative, okay? Their diet needs to change, probably. Yeah, lots of fluids, leafy green veggies. Fiber, exactly, all of those types of things. Okay, what else? I'm seeing if there's anything else I want you to. Oh yeah, there's a couple of things I want you to bear in mind. The types of laxatives, the bulk forming laxatives like Metamucil or cellulose. The patient, has anybody ever seen it? You mix it with water and it turns into this lumpy thing, yeah? They need to drink that straight away, okay? Because you don't want them getting a big chunk of that in their throat and obstructing. Does that make sense? So when they mix that thing, they need to drink it. Because that thing is going to congeal pretty quickly. All right, and be aware as well, anticholinergics, like I said, anticholinergics, they're going to dry everything up, right? So anticholinergics are going to decrease peristalsis, because remember, it works a little bit like the sympathetic system, that those two work together. So it's not rest and digest, it's the opposite, anticholinergics. Okay, that's a lot to remember, right? We're almost there. Do you want a quick break?
Yes.
Have a 15-minute break. I really want to get these last two chapters done.
Now, that is also good for the headache, right?
Yeah. But, I will be back in 15 minutes.
Sure, that's the gut muscle too.
I want to get these last two chapters so that I can have the opportunity to go over exam number 3. So give me 15 minutes.
What's the next chapter?
52. We've only got 52 and 53. I'll probably get that done in half an hour.
Okay.
I'll be back in 2 minutes.
You all right?
Okay.
You said serum or serum?
I think so, we did cardiac last night.
No.
That was today.
Listen, listen, she was talking about Sarah and Sarah home.
You said serum.
Serum level, like what?
Shit, I ain't doing one damn acting. They should have taught me that. Serum level is 9.0 something, right? That's what the acting thing said.
The serum level of what?
Shit, I don't know. Don't worry about it. This can get out of hand.
What the fuck is serum?
Those.
Let's go back, what is serum?
I don't know, I just read it. Some of the liver. Is it with the liver?
It's with all kinds of stuff.
So a serum, I think, I don't know how to explain it, but there's serum level for what calcium, magnesium,
For almost
potassium, all of them.
So it's
the
the
blood.
blood.
So that's usually serum, that's it, right?
That's the serum.
That's right, okay. So that's you.
A serum. How much is in your blood?
It's all you said.
Can they get a range?
I think that she said serotonin. It's like, you heard 10 different.
That's all I heard.
Figure out where they're
I
getting
just
it.
heard
They got serum biology.
He was like,
Yes, Perfect.
oh,
I feel like I am though.
but I remember I seen
You are, though.
one day we were supposed to.
Y'all start using my car or this is big. My kids ain't home, so I feel like a baby.
I don't know, why do you think my attendance went back down?
They get it. My kids ain't home.
You got that. What is it? What's down with it?
I didn't even learn about it.
I don't know what's down with it.
I know one thing.
I know somebody out here.
Oh, no point.
Yeah, scamming it out. Bank card, cash out. They scam, they finesse. Scammers are finessing. Yes.
And then,
I just want some friendship.
Pause
A
your
close
card before you even do it.
Okay.
They do.
Listen.
But they're good about it, they're proactive. We're gonna send you a letter, please be assured that we take this thing seriously, we won't hopefully to resolve. It's not resolve nothing, I told you I was saying,
I want my
I
money.
want my money.
And I don't want it now. I want it and I don't want it now.
Yeah, it's like you just use it, no one talking fast, I don't have my laptop with YouTube. Why I want on YouTube, who the fuck orders on YouTube for $70?
When I bought this, off my little line, they got mine, 3 times. I had to- Because they my bank and say, this is me.
That's the funny thing though.
Because if it's a big purchase, they'll.
Well, that's what, I'm gonna go to Geo Vista. You know, I live in a small country over time, so all we gotta have a one spot go up in the American to Geo Vista. So,
I'll go to the small bank.
No, because I work it's a credit union.
I worked at a credit union, they get hit a lot,
Yeah,
they
they
get
get
hit a lot, they get a lot of, they get a lot of breaches.
What's wrong with that even worse? It's not a credit union.
Bank of America is the best one.
But
But they will nickel and dime you though too, make sure you don't go over on your account, because they will turn around and they will nickel and dime you. Overdraft fees.
I don't, that's why on my card, I can't overdraft.
Oh, you took the.
that be on my card, I can't.
It's always in the account where you can overdraft, because decline that, decline the other, they put me in the most.
Exactly, I'm not gonna let you grab me. I ain't gonna be shady. I'm gonna damn so, I'm saying, I'm like, that shit, that's all right. So that shit, that kind of, I be needing so. Period. And my pocket. I can be a woman, bag, look, shit, my pocket, and this shit, low, just don't whisper to me, bitch, somebody said that loud whisper. So bitch, don't say it loud, get angry.
Ma'am, your card is declined.
No, I cannot whisper. No, I'm very for my whisper. That bitch get next, put your body blind, then. Shit, I'm telling you, pay me.
No, don't sit your ass down, dog.
Like, you put this motherfucker shirt, you got motherfucker steak, bitch, you ain't no fucking money.
Oh my God, dog.
On my life,
That fucking shirt, you can wear that fucking rib eye, the bitch can't tip.
You see that?
We're about $14.99. You bring in 5 children. churn, or they chopped the
Churn.
Oh, they did.
No, they had 5 churn, you go to 135, and you leave, I thank you, you break 30, but then you don't come back here. Come back here, military discount, and then they take that 10% and they take my tip.
See, that's why I can't, that's why I can't. See, I got these fucked up in my mind.
So when I got my
I gave my
boyfriend,
I gave my
See, me, I'm just stingy. I ain't giving you shit. I say what the fuck I ain't giving you a motherfucking thing. This charge to the game. You apply for a job to somebody in the house. I ain't telling you about it. Sit your ass down. I'm giving you nothing. Come on, I paid for my food. I'm going to you broke ass bitch. You I can't even. I can't.
Well, see, I don't need tip. I just don't believe in tip.
How the police don't come in and look away there? See, black people like me, and then you say,
I didn't tell you I love that job.
I was running on $50 fucking food, bitch, run me for 5 motherfucking refills. That ain't free. Then I give my fucking bread to go. So you ain't tipping, bitch, I got $7.
Bitch, I'm not giving you no bread, bitch. You
Don't ask me no bread. Don't ask me no bread, then. Don't ask me no bread. No, it's not doing nothing. Don't ask no strawberry lemonade to begin with weekend. It's customers like you. It's customers like you. We order some water. A cheap ass time, okay? You gonna tip me too. You gonna tip me. I'm gonna charge a card anyway. I'm gonna add a tip to the card. I'm gonna add a tip to the card. Don't tip me, bitch. I'm gonna add $10. Whatever that 3% is, if you wanna take both receipts, bitch, you add it. You better take all 3 fucking receipts and signature on it. Bitch, the merchant copy is added like tip that shit. You pay out that money. If not, you gonna have to call your account. If guess what? You know what? Guess what? $2. If your bill, yes, you are. Don't tip me, then. You gotta have, they don't play card, my card, don't tip me. You have a fucking fraud alert in your account. I can't. We don't know 3 days later. Only thing short is the job. 3 days later. Bring that ass there. Or you gonna keep on doing don't tip. I'm gonna get my phone going. Yeah, you last night. That's why when you took on my cord.
No, for.
Better let you say. You don't take all the receipts. If you need the customer copy and the merchant copy, I'll do that shit. I'm gonna take the merchant and the guest copy, get copy and sign the merchant to get that. And now
Mondays.
See, okay, I'm glad you said it, 'cause I ain't giving them bitches shit out.
Oh, they done changed it.
I'm gonna read mine.
It was an announcement she sent, like in the email, it was like
I
online.
spent $60 on my bill, bitch.
60, bitch, that's what $14 tip.
Bitch, I ain't even shit.
You tell me eat for $60.
I guess 8, so Monday and Thursday, Lee's on, Tuesday and Wednesday, yeah, you're right.
All y'all gonna find that same black folks, Mexican folks, and Indian folks, who are gonna be slavery. What is the stingy?
I don't believe in tips.
You don't believe in tip? It's gonna be the other thing. We work from home.
Okay, I got no problem.
Y'all think you want 45 or something thing?
But who told you? Why the fuck you gonna have a job $2
So y'all are back to back. So y'all are 2 days in a row, it's like Tuesday and Wednesday. And ours is Monday and
Why would I
Thursday.
go? Listen, you take something, Alicia. Saturday, I made $350 Saturday. And 2 days, I made $600. You know what? Motherfucker, I can't answer my face.
Tuesday and Wednesday. Nope, that's 8, so that's 8. So yeah, it's Tuesday and Thursday is 8, and Monday and Wednesday is 8.
They need to hear me. Bring the damn beat of Dawn down at night. Bring the Dawn down.
Yeah, 12 hours.
shit, let the mom talk, I got
And then at 8. Well, these are like 8 to 12:30.
Oh, you hear this shit?
If I'm with you, I tip, and if the bitch work for tip, I can.
No, I'm gonna tip like you did, but you gonna tip
Yeah,
her.
those are 8 to 12:30.
Well, then you can tip.
I will, but I have to.
Come out my
I can see if people like your ass.
But those
They
are
come tip $60 to leave.
I'm
So
sorry.
Six,
I
I ain't tipping
like
no
go.
motherfucking
I run behind people that you like go. I run behind
So that's a
y'all.
7, 8,
Yeah.
6, 6, 7, 8, 8, and then 8, 7, 8, 7, 4. So okay, this is the alternate rate. That's what that is. So every other week you'll have one say, that's A, that's B, and then that's B, and that's A, B, A. So we're gonna every other week do this 8 hours. Then we have this 4 hours. So that's for everybody, I guess.
I'm asking you first,
Yeah.
y'all talk to me. I don't know shit. I don't know shit.
So I guess it's there a lab. It's a lab.
If you need a merchant in the
Do you know, Paul, can you look at this?
for 14 extra dollars.
You gotta go to jail.
I don't want to go to
Let me
jail.
say this on my back. I'm on my
Is
way.
this stay in a lab for everybody? Or is that what that is?
Bitch, who's my right?
So we alternate that. Like, one week it's one. Okay, so that's a lab for
You better take that copy and the merchant copy. It's not done to go as far as that card. Believe that. If your bill $50, don't add 8 more to it.
Whoa.
If your bill 4 on tip me 8. If you didn't anything less than 8, I'm adding more to it.
You're supposed to take the first two numbers, times it by 2, and that's 20.
Oh, no, stand up, girl, stand up. Stand up, stand up. I'm not saying down, run for your ass, you can't make all my goddamn shit up.
But you
Don't
you tip
you
$12.
tip? Let me talk some damn tip.
First of all,
You just sit down.
it's
Don't
not
show
your
me
bread.
within 30
it's
seconds
not
of
no
the cake.
strawberry.
That is my shit, I'm giving it to you.
That
The
ain't
moment
your
I fix it, it's my shit.
nigga, you clock in.
I don't give a fuck.
Nigga, you clock in. That ain't your shit.
The moment you
That's
sit
a white
down,
girl shit.
that's why I can't serve your ass.
That's a
You
white
know I can't serve right
That
there.
ain't your shit. It's a people shit.
Believe me.
That's
I'm
a
listening. You tell me what you tell me.
Honestly, I took whatever cash I have on me. If I don't have it, I
Do y'all know this is being recorded?
That was my shit.
Hey, Donna, somebody asked me why I got it. Donna. Everything you're saying is being recorded.
She don't care, I take her damn card too, and she took my stuff, don't tip. She exempt, if she don't take the merchant exempt off, use her damn card too. It's like you gonna tip my ass too. So bring like the row house, what the fuck we do at row house, job bread calls. This week one that shit, I am mad.
Okay.
I ain't lying. Don't tip Donna B. But we gonna have the pool and not tip me now. You said she gonna record, from the pool.
There's kids that, there's students on there.
Oh, they can listen, I take a damn card too, they really have to put my damn job, stay in them. I'm gonna use their damn card too.
What you say
I'm
about
gonna use my own card too, I'm gonna look here, come in, don't tip. And need both their credit card, go ahead, got it.
Thursday. You better not go to a restaurant.
They better not go and don't tip. They don't do what I do. You do like, oh.
I don't know Jamal on there, but I know Jamal is on there. She's like, why is she watching? Jamal, I don't know who's all on the team thing, but Jamal is on there live, but I think it's all.
She got a leg for
I'm sure they can hear her in their office.
I'm gonna give you the pro, I'm gonna give you the right check. The military discount check, you keep that shit. With your fucking regular ass legs for it, you can't, you do it for that fucking hairstyle you got on. Just them showing people coming up, you don't want someone to tell, you take out that shit. Them girls that come in bougie and shit with their eyebrows and the lace on, them bitches don't tip, bro. They don't tip nothing. That's the worst fucking one.
It makes me like,
You can't, $300, I say, yeah, the bitches don't tip their hairdresser. I tip my hairdresser, 20%.
At least $10.
10? I wouldn't know fucking ass. Braids in your hair, you my tip. You like you braids in your hair, I thought you did the damn hair for 12 hours, my tip.
These is $2.79.
Oh, you charge me. She got you $2%. You ain't tipper. Oh, shit. Oh, come on, my daughter. Shit, we need 2%. Go with 2 or 3 and include.
See, that's what black folks nowadays bitch. Like, bitch, you get what you give. That's what you gonna get. You gonna get what you give.
You're gonna get what you get, not get what you
Whatever.
get.
Yeah, I ain't getting nothing lately.
I had this young lady that used to be there. She got sick.
Did she stay in nursing, not wellness?
I haven't seen her there anymore.
I can't take Kirsten seriously. I thought she was going to. I thought she was.
Oh
my God.
I'm not gonna go there again. We haven't seen a person.
I do like too.
Things like that. So for them.
I said everywhere I
Now
go.
it's like.
Y'all got it.
What?
Yeah, because I mean.
I know that's funny. I like the nursing breakdown.
Even though I still.
The nurses breakdown.
But you from Georgia, that fat cat down here. Fat cat, that's not Georgia thing, baby. You from Georgia, that shit dry as fuck. Y'all supposed to look at that dry. You from Georgia, girl, and I'm looking at the phone, that wet. And it's all. That's that Georgia girl shit. Like I know dry, damn good fire shit.
That's why Laura had dry mango.
Laura ain't shit dry like Laura is. Laura from Georgia. She ain't no wrong with shit. She a Georgia people. She got motherfucking Niagara Falls. Y'all got eat sour and oranges in Florida. The hell? Talking about Florida. I ain't had a sweet orange yet in my Florida. I went to the Georgia sour as hell. And steak and shit too. Shit from Georgia, y'all dried up, put us in the mandarin oranges. Fuck around, you that look.
And then I'm gonna do an exam prep with you for week 9. Okay,
Girl.
you ready? Chapter 52, antiemetics and anti-nausea. Chapter 52. So when we're looking at the what's called the chemocenter trigger zone, there's various different aspects as to why somebody might get nauseated or vomiting or something of that nature. It could be something that's going on with the GI tract that triggers it. It could be an inner ear issue, right? Like Meniere's disease or an infection of the middle ear. Or it could be a brain issue from the cerebral cortex. So there's many different reasons that can trigger somebody to want to vomit or feel nauseated. And then it goes down into what's called the medulla to the vomiting center. And that's what really can trigger somebody to vomit or feel nauseated. Now, one of the big things on page 811, I need you to know this because it will be on your exam. It talks about the syrup of Ipecac. And I don't know if you know about this, but we don't give it anymore.
The little burgundy syrup.
Yeah. We do not recommend doing that anymore. We do recommend that families keep the poison control number on their fridge or somewhere where they are going to find it really quickly if they need it. Okay, but there are steps, like it says, keeping poisons out of sight, of course, and reach, secure containers, don't refer to medications as candy. All of those types of things are what you're going to do for these patients, for these peds. All right. So let's just look at some of these medications. One of them, again, look at this, Donna, anticholinergics. Anticholinergics, all right? Again, because they do various things, okay? They dehydrate, okay? They reduce any sort of secretions.
So they kind of, they like stop nausea. How do they affect it? Like, what's the relationship between those and nausea and vomiting? I'm only asking because I see it right here.
So it says it right here. What they do is they block acetylcholine receptors.
And that's the, so would that be like, because that's the antidote for pain for Tylenol, right? That's not the one in acetylcysteine?
Acetylcysteine
Oh,
is,
okay,
but we're talking about acetylcholine, which is a neurotransmitter.
okay.
Okay, so you're getting me confused now. Oh my gosh, acetylcholine is blocked. So when acetylcholine is binding, basically when acetylcholine is not able to be utilized, that's when that message is not transmitted to the vomiting center. That's why I was saying about these vomiting centers, the different things that can happen. So if you look on the top of page 811, where it talks about the GI tract. Hey, hello, gosh.
Oh, hi.
Oh,
Girl,
hi.
you want me to see that? I love that.
Hey, this is about the funds. Has surprised us.
Mr. D, you back? With Winmar? With Winmar?
Yeah, Miss Winmar.
I always got
It's
on.
Winmar.
I did great, girl. They took me far.
I made a 51. I'm not that.
Well, the good thing is you got remediation and now you know what you need to work on.
There you go, girl.
So my question about remediation.
Can you sit that up first?
First of all, let me just say, yes, congratulations.
Thank you.
Am I speaking to you? Yeah, all right, very good. So congratulations, on the testing. The score, and I'm just gonna talk numbers, not names or anything, so, in looking at this information, the high score was 936. And that's phenomenal, so you must know who you are, so congratulations to you for that. But our lowest score was, oh, I have it down here, 392.
And that's okay to work.
And that just means that, we've got some room for improvement here. But what I really wanted to share was in reference to that conversion score that we talked about. And for this class, it's what? 60, that's correct. So, we had one person whose conversion score, that 900 person, was 82.91. And then 7 of you scored in the 70s, anywhere between 70 and 76. Another 6 of you scored between 60 and 69. So already we're at 14 people who would have passed had today been your day to take your practice, or your final HESI for this course. Then 7 of you scored between 51 and 57. That 57 person means you just needed one more question to be at 60. So this is not unreachable, is what I want you to know, because that would be 21 of the 23 students in this class. So please know that you know more than what you think you know, and that's exactly what Adon Newell told you guys a few times. But it does mean that you need to study a little bit more. And then the 2 people, we're gonna, have some separate conversations with those who are falling a little bit further behind, because we want to make sure that you can gain some momentum and ground as you go to take your final exam. Now, I do want to mention on one particular person, because you don't see this often. We don't really look at the raw score, which is the 3 numbers, like the 936. We don't really look at that. Well, we do, we care about it. But we look at the conversion score, because the conversion score lets us know how you're thinking, if you are getting those higher level questions answered. And that's what's important. So whoever scored a 467 actually had a conversion score of 54.9. I don't see that ever. What that meant to me is that person answered the hardest questions on the exam, but didn't do well on the easy questions. So that just means you need to study a little bit more, because you got it. You've got the knowledge, you're understanding, but you need to make sure you study the content a little bit more, because they would have been only 1 or 2 questions away from passing with a 54 versus but that number was a 467. So that was kind of interesting to see that lower raw score versus that conversion score. So I just want you all to be encouraged because you are pretty much on track for where you need to be right about now. And so, you know, the remainder of your time in your class, we will work with you. And who was it that asked me if we could manipulate a little bit of our clinical time? Oh, you did? So exactly, that's what we're gonna do. A.R. Davis has pulled the concepts. So tomorrow, the first 8 hours, we're going to do some covering of all these concepts to make sure that you're good. And then you'll do 4 hours of clinical because we have to get in some clinical time too, okay? And then we'll see where you are on tomorrow with everything. And then we'll gauge what we need to do for Friday's time, okay? Any questions about that?
I think it was easy, not easy, it was understandable. I told Mr. D, I think where I'm at a 463, got like a 53 on it. But I told him, my name is Donna though, by the way.
Okay.
But I told him, I stated that the reason why I got that, because I understood the priority of ABCs, but when it got to other priorities, I was still looking for the ABC priority and not the priority for different diagnoses. That's why I think, because I realized, like, once I did it and saw the remediation, I was like, oh, I knew that. But because I didn't realize the priority was different. That was the only thing there. The priority, not realizing, okay, after ABC, what's next? But I guess that's different depending on the diagnosis as well. You know.
Right. Okay.
That's actually pretty good. It was, you know, especially not, you don't know anything, coming in with not any nursing knowledge. So for me, a 53 for me was really great because I was like, I came in not knowing anything at all.
Yeah.
But through the teaching, you know, I understood a lot more.
Another 5 questions in your class, right?
Exactly. And then 3 of those are dosage cows. I'm still struggling in that area myself.
Yeah,
So,
yeah.
yeah.
Awesome. I'm glad to hear that. What about some of the others? What did y'all think about the test?
It wasn't bad.
It wasn't
It
bad.
wasn't bad?
It was way different from what I expected.
It was way easier than the farm.
Yes.
Unfortunately, farm is hard.
Get a critical thinking, I think, or
The hardest one.
And over.
But you do very well.
Yeah.
Really good.
Yeah. Trying to learn exactly what I'm looking for. Instead of, like,
No, you need to go back to art class.
Naturally, I thought the math on it, but I only thought that due to COVID versus giving them.
All right, I really wanna.
So you know, thank you.
That was split. That doesn't mean you still who's going up there.
I know, we got 45 minutes.
That's what I'm gonna, yeah.
I'm gonna say it.
Yeah.
That's correct. That's correct.
I'm not trying to be rude, but we only got 45 minutes left to learn about an exam we're fixing to have.
Okay, all right, well, that's me and my time to exit. Thank you so much.
Thank you.
You guys did well, thank you, Professor, for letting us come in.
Hey, can I ask a question? Is there a way on Evolve to print our remediation packet?
No, they won't allow you to.
Because I've talked to 2 different people and they both told me I can.
No,
Brenda and
I think that used to be some time ago, but I think they changed that because people were passing it around and all kinds of stuff. So they have now protected all their documents. Yeah, yeah. Last term, someone asked too, and
I was talking to
Maybe they get
support
the My Evolve support people. Like I'm on the My Evolve, I'm looking at my remediation, and I did like an online chat with them, and they said I can.
Okay, well then,
I
because I spoke with somebody last term who told me I can.
Yeah.
Let's check
The
it out.
person I was just chatting with said she lost connection, and she hasn't come back on there, but she said I could ask her how I could do it.
Okay.
So,
I'll check, okay.
So.
All right.
We gotta go because they want to really finish their lectures today, and I apologize, but we will come back on tomorrow. All right.
What's her name?
Director Caldwell.
Girl, what?
That's what we look at all the time. Here you go.
That's funny. All right, we're almost, okay, we're almost done with these chapters, guys. Thank you, Selena. That was really cool. All right, so you understand about the cholinergics, what I'm talking about, that it dries everything up. You gotta do something? Okay, no worries. On page 812, oops, sorry. I hate standing behind this thing. I prefer doing that, but I'm trying to stay in the middle a little bit more. It's got the different types of antiemetic drugs here. You've got your anticholinergics, like I just said, your scopolamine patches, things of that nature. Then you've got things like antihistamines. What would be an antihistamine? Give me, thank you. Yeah, diphenhydramine. Yeah, that's your antihistamine. Then it goes to stuff like anti-dopaminergic drugs. So again, like I just said, a lot of these meds are used for other things, right? So these anti-dopamine drugs, basically reducing the effect of dopamine. That's things like phenergan, prochlorperazine, and promethazine. Yeah, where am I? Page 812. So these anti-dopaminergic drugs, they block the effect of dopamine. So that's stuff like phenergan, gets used a lot. Prochlorperazine.
Promethazine.
Yeah, promethazine. Mm-hmm.
Yeah, that's maybe the third stuff.
Yeah, cough.
Yeah, for the cough.
Say that again?
That's like the stuff that they use for the cough, right? That people use promethazine.
Phenergan, I think you can use that in a combination. I'm not sure. I'm not sure about that.
Isn't it being given to like pregnant people doing nausea? Like pregnant
Yes,
women that have it?
yes.
It'll knock it out.
Yeah.
Okay.
But you have to be aware, okay, so understand it has an anti-dopamine effect, okay? So bear this in mind. So on the central nervous system, it can cause a sort of Parkinson effect. Remember we showed you that video of the Parkinson guy? Remember way back when we talked about Parkinson, I showed you the guy that was shuffling gait and all the rest of it. That's Parkinson's, right? It doesn't have enough dopamine. So we give them dopamine to help them.
It stops tremors, right?
Yeah, it stops tremors, rigidity, all of those things. But if you're giving something like phenergan or promethazine or one of these meds, because we're blocking dopamine, potentially it can cause that effect. Does that make sense? I know it's
psychotic effects.
It can cause psychotic effects, yes.
Okay.
And it can cause, this is the word I want you to know, extrapyramidal effects.
Pyramidal?
Yeah. Extrapyramidal symptoms.
That's the medium.
Yes, it's in actually on page 813. So think, when it talks about those types of symptoms, think your Parkinson's patient. Think that tardive dyskinesia, tremors, all of those types of things is what I'm talking about. All right, some of the other ones that are used. This is a biggie. Prokinetic drugs, like metoclopramine. Or metoclopramide, I apologize. That's another one that blocks dopamine receptors and helps reduce nausea. And then we have our other one called serotonin blockers. So although serotonin is good for us, right? In this case, we need to block it. That's your things like Zofran. Odenastron. Zofran gets used a lot for things like chemo. When Zofran came out for chemo, game changer. I love it. It was a game changer. Not that patients didn't get nauseated and sick, but it's a game changer in the oncology world. All right. So just looking at a few of these, scopolamine patches. I told you about my episode with a scopolamine patch, right? Oh, yeah. Yeah. One eye bigger than the other, right? It dilated my pupil, but if I'd have had glaucoma, that would have been a problem. Yeah, that would have been a real problem. But it will dilate your pupil, but yeah, and you won't be able to see. Anticholinergic, that's what they do. You can't see, you can't pee. That's part of it, isn't it? There's several, there's a little anachronism, something like can't see, can't pee.
Can't spit, can't shh.
No, it's not no red. Red is a big
That one was on
group.
YouTube. That's the one I seen on YouTube.
But there's one, yeah, there's one anyway, but anticholinergics. So now you know. But scopolamine patches, contraindicated with glaucoma. So any anticholinergics, if you see anticholinergics on your exam, think not good with glaucoma, all right? All right, antihistamines, of course, they're great, but they cause drowsiness, don't they? Antidopaminergics, prochlorperazine, promethazine. We use them all the time.
They're all antihistamines, right?
No, ma'am. Antidopaminergics. Your Phenergan and your Compazine. They're great, but as I say, be aware for that extrapyramidal type of symptoms, your tremors, those types of things. Now, I do want you to be aware of promethazine on 815, page 815, promethazine. This thing burns.
They never heard me.
Well, lucky
They probably
you.
diluted it.
It burns. Yeah, they probably diluted it. And let me tell you,
That's why.
this causes, this medication definitely can cause, as I say, that type of extrapyramidal type of hypotension, all sorts of things. It can cause a lot of issues. You do not push Phenergan fast. You push it slow, you dilute it, and you give it with, yes, yeah. Well, it's, you can push it, but you have to push it really slowly. You're going to do a slow IV push if you do Phenergan. But with your push, you push it in with a running line. So you've got a running line of fluid, saline, something like that. Normally you flush your line, then you do your Phenergan slowly with at least 10 cc's of fluid.
And then they rather give it to you orally if they know. If you-
It-
No, I always try it orally. It's like I said, it'll burn.
Yeah, but if, okay, let me put it to you like this. If you've got a small bowel obstruction, can you get it orally?
No.
There you go. So no, right, if you can, but you need to understand that this can burn, okay? This thing can burn. All right. Let's see, the other one I want you to know about. Metoclopramide. Metoclopramide is a prokinetic drug. This one increases GI motility, and the reason I want you to be aware of it, it's also called Reglan. And this particular medication is actually good for, it says GERD. It's also used as an antiemetic. But the other thing it's good for is helping with gastric motility. Okay, so sometimes it's used for that. It's not always used as an antiemetic. Last two, serotonin blockers. They block serotonin or 5-HTP. And that's your things like Zofran, ondansetron. And as I say, it was a major breakthrough. definitely a major breakthrough. It's used for hyperemesis. Anybody ever heard that? Hyperemesis, gravidum? You did? Yeah. Some people really suffer with that. Oh, it's such a shame. One thing it does say though, ondansetron is pregnancy category B, but there is a concern regarding developing a cleft palate in the first trimester. And then the only other one I want to mention is Marinol, which is one of the cannabinoids, and we've been using that Marinol. It's a stimulant. Down at the bottom there, Marinol. It's used for nausea and vomiting, but it actually does stimulate appetite and weight gain. All right. So the big thing to remember is what? The anti-dopaminergic drugs. On page 817, halfway down, it says, care of CNS, central nervous system. Watch your mental status with these patients because they can get what's called extrapyramidal effects, adverse effects. And now you know why, because it blocks dopamine.
So anything that blocks dopamine would have an extrapyramidal effect?
Potentially. I mean, not everybody, but I will tell you, my husband, when he was in the hospital, they gave him Phenergan. They pushed it really fast, and he went into a tailspin with it. Yeah.
My dad has.
Back to south.
He has severe nausea and juice, so Phenergan, he prescribed it at home, so. Right, that he's had it,
So, all right. So I want you to be aware of one of the herbs, because this sort of stuff always comes up on the HESI, right? Now you know. All right. So there's a yellow box in the farm book with things like feverfew, ginseng, ginger. So ginger. Which is why we get ginger ale. Or ginger tea. Ginger candy is great. I'd rather have ginger candy. That would be my go-to. Ginger. All right. This will take 10 more minutes. We're actually till 3:30. I know.
No, I didn't mean that.
But you'll be happy. All right, last chapter. We have our vitamins and minerals. So, I call them vitamins. Vitamins, chapter 54. Not vitamins, vitamins. That's how you do it. Vitamins. All right, so you've got your fat soluble and your water soluble. And I know you know the difference because I saw
Vitamin A, D, E, and K.
Thank you. Oh, what?
Are fat.
Yes. Which are the water soluble? B and C.
Are water.
Yeah, you got it. All right. So I think a few things that I really want to pull out of this is, well, there's some cool things in here actually. Excuse me. I tried to drink a little bit of tea before I came in here. Cheers. Oh, whenever is that what you do whenever I drink?
Every time we remind everybody after to drink, we say cheers.
Oh, that's great. I love it. I love it. All right, so let's look at some of these B vitamins. Oh, let's look at vitamin A. Vitamin A. Yeah. What's vitamin A good for? Yeah. Where do we get it from? Get it from a lot of different things, right? Eggs.
Carrots.
Yeah, carrots. That's the whole thing about rabbits and good eyesight, right? Because they eat a lot of carrots. I don't. I don't really. But anyway, any colorful types of fruits and vegetables usually have vitamin A in it, carotene. Okay. They have beta carotene in it. So vitamin A. And of course, symptoms of vitamin A deficiency could be what? Yes, night blindness. Says it a bit further down, right?
Yeah.
So anything to do with the deficiency in the eye could be as a result of a reduction in vitamin A. Now,
Mechanism of action.
what I need you to look at is table 53-2 on page 825. I like this because how many times on an exam have you now seen? So many. Thank you. About
I had one today.
foods, right?
A lot.
This right here is your little cheat sheet that I like. So vitamin A, egg yolks. Think your yellow types of things. Egg yolks, dairy products, yellow, orange fruits and vegetables. All right. I'm not going to go into too much detail. There. Vitamin D. Let's look at vitamin D on 826. So people always think they have enough vitamin D because they go out in the sun. Every single person, I test their vitamin D. Every single person, part of my panel, that's my normal standard. I have yet to meet anybody who has a decent vitamin D level.
Isn't it like 5,000 or something?
You need to take at least 5,000 IUs of vitamin D every day.
Well, I drink Sunny D.
Not so let's look at why it's important. Let's look at why it's important. You've got vitamin D2, ergocalciferol, and vitamin D3, cholecalciferol. They're slightly different. One is plant-derived, so you get it through your diet. That's the D2. D3 is the one you tend to get through the sun. Okay? But the problem is you really don't. You're not really able to absorb it, and you desperately need it. Let me help you understand. Multiple sclerosis occurs more in northern states than in southern states because there is a correlation with vitamin D and things like MS, just FYI, okay? That's not the only reason that I want to talk about it. What's the big deal with things like bones and vitamin D?
The bone did it, don't you? Like your back, you don't take enough.
What does vitamin D do?
What the bones, like milk?
It upregulates calcium, doesn't it? Why do you think it's in milk?
What kind of milk? Whole milk?
Any milk, isn't it?
So I asked that too, because you know what they're teaching kids now in school, that milk is healthy for you.
I know.
So that's why I asked that question.
Well, that's a whole nother set. I'm just going with the basics right here, all right?
I'm just trying to make sure all
Yeah.
you can say my calcium. All milk.
I drink almond milk. But anyway, let's look at this a second. What does it do? Vitamin D works in coordination. Can you guys stop so that we can, I want to really finish this off. Let's just
milk that you're talking about, or vitamin D. You don't understand.
I first of all want to explain to you what vitamin D does, and then we can talk about milk a bit later. But let's talk about this first. All right. I want you to understand vitamin D works with the parathyroid hormone and calcitonin. And calcitonin comes up on exam. It's going to come up on your HESI. I promise you, it will come up on your HESI. Calcitonin regulates serum calcium levels. It increases calcium absorption. So you need vitamin D to increase calcium absorption in the body.
And phosphorus, right?
Yeah. Guess what calcium and things like phosphorus do? They make a bone. They help make bones. Okay?
Is that in this chapter that the drug we're talking about, the calcium?
Yes, calcitriol.
Oh, calcium, okay.
Yeah,
Okay.
it's on the HESI. That's why I want to talk about it. All right. So the compound, it's basically converted from calcifidiol to calcitriol. And that's the most active form of vitamin D. That's why I want you to know about this. Calcitriol is the most active form of vitamin D. What does it do? It promotes use of calcium and phosphorus. So what do you think it helps with? It helps with the development of bones and teeth. Now, we don't really see rickets in this country. I don't think we see rickets in many countries, but maybe if you lived in a country where they didn't have great food and vitamin D and all the rest of it, you may see something called rickets. Usually in young children, they have bow legs, knock knees, because their bones haven't developed properly. Okay, you may want to look it up, rickets. But you will see it a lot with young children, infantile rickets. Tetany is like this, tetany, and you might see basically low calcium. Okay, I remember once I was really young, just started nursing school. I was doing surgery rotation, and they did a thyroidectomy on a patient, but they also inadvertently removed her parathyroids. Well, we just read right now, what do the parathyroids do? Work on calcium. So it lowered her calcium. When I went to do the vital signs, she was beginning to do this, because one of the things you do when you check the tetany is you put a blood pressure cuff on. And actually, they will have a very spasm type of effect when you do that with a blood pressure cuff. Well, I'm like 18, 19, I do it, and I'm like, what on earth am I seeing? And she had developed tetany as a result, because they took the parathyroids out, okay? So, please be aware of the importance of vitamin D. It is so important. Why is it in milk? Probably because milk was touted, I don't know all the marketing behind cow's milk, but I'm going to say in the sort of 40s and 50s, maybe rickets was more prevalent then, or even before then. Milk is easily given to people, it's cheap, it's easy, so why not put vitamin D in milk to help upregulate it and prevent people from getting rickets? That's what my thinking is, and I think there might be some rationale behind it. Someone look up that background. But you think about it, in developing countries where they don't have a lot of food, they will give sources of milk, right? They'll give dried milk because they don't have it. So it's a good food source. It's not that it's bad for you. It's just, if there's other sources that we can use, like almond milk or coconut milk, we're just fortunate that we have other sources. But I mean, people who own a farm and have goat milk, I don't necessarily know that it's bad for you. It's just that's something that people are beginning to say, because we are a rich country and we're able to have all of these different resources. I think that's a lot of it, quite frankly. But I don't know the specifics. But what I do know is that milk is a cheap, easy product that has a lot of protein in and things like that, and good fats. So that's going to help prevent, if they upregulate it with vitamin D in the milk, prevent things like rickets occurring. Does that make sense a little bit? But I'd love you to look it up and let me know why. Dr. Quinn isn't a fan of letting people drink milk either, so. All right, vitamin D, 1 to 2,000 units. I always say 5,000 units, at least 5,000. But you can see people prescribe 50,000 as well. Sometimes I'll give them 50,000 per week. So, all right. So let's see. Calcitriol on page 827 is going to be probably on your HESI. Calcitriol. It's available in oral and injectable form. Vitamin E. Vitamin E has a lot of different aspects to it. It's the tocopherols, alpha, beta, gamma, and delta, and it's an antioxidant. It's a beautiful thing. Vitamin K. What do we use vitamin K for? It's an antidote, right?
Yeah.
Thank you. It's a blood clotter. On page 829, it tells you what it's the antidote for. It's the antidote for warfarin.
You said the antidote for warfarin?
Warfarin.
Vitamin K, right?
Coumadin.
I thought.
Yeah, coumadin, warfarin.
Okay.
Okay? But it also, you know, it's a vitamin, okay? So it's a great thing to be utilized. It's just, again, we don't want to use too much of it. Vitamin K2, I can't even pronounce this, menaquinone and menadione. So we might need to give vitamin K. Supposing somebody has issues with coagulation, right? What if they have, what's the word I want? Factor VIII issues, clotting issues. We might give something like vitamin K to help with that. Hemophilia, that's the word I'm looking for. So if they've got some clotting issue, we might have to give vitamin K to help with that clotting issue. Okay. Let's see, what else do I want to say? Aha, let's do the water solubles, the Bs. Okay, we've got a lot of different B vitamins, which is why sometimes you'll have a B complex that you'll give patients rather than them all having to take different B vitamins, right? We'll give them a B complex. On page 830, there's your list of B vitamins. At the top there, box 53-1. So I just want to go through a couple of them. B12, you might hear it called cyanocobalamin. Okay. Folic acid, we use that, don't we, as prenatals. Why?
It helps with the development of the neural tube defect in like the brain.
Yes, yes. It helps prevent any deficits in neural tubes. Absolutely. So that's B9. We use things like thiamine, B1, riboflavin, peroxidine. These things have a lot to do with the nervous system. So we might give what's called a banana bag, say to the patient with Wernicke's encephalopathy or beriberi. You might give it, say, the patient that comes in the ER, the alcoholic. They'll often get what's called a banana bag because it has a lot of B vitamins in it. It helps with cognition. Okay. So when you think of your B vitamins, think of your peripheral nerves and also think of the brain. All right, B1, thiamine. As I say, that helps with what's called beriberi. That's a thiamine deficiency. Pellagra or pellagra is a niacin deficiency, which is B3. Niacin also gets used as what? We talked about it in a couple of chapters ago.
Cardiovascular factors.
Yeah.
Bloodstream.
Yeah.
Mm-hmm.
We use it for what? Cholesterol. Cholesterol.
Cholesterol. Okay. Cholesterol.
It's used as a statin. Yeah. All right, B2, riboflavin. Now, if you see somebody that they have like fissures right here, and their tongue could be very, it's called glossitis. Their tongue is very red and sore looking. They might have lines right here, like red lines right here. That's a riboflavin deficit. So you might see that a lot in your alcoholic. And remember, like I said, B vitamins are good for patients with peripheral nerve disease or brain issues, things like that, okay? Anxiety, all sorts of things like that. So think of that type of patient. These are the patients you give your B vitamins to. Riboflavin. By the way, riboflavin will turn the urine orange, yellow. B3 is niacin, like I just said. It will cause flushing. And let me see if there's anything else I want to say about that. Yeah. It can cause hepatitis and abnormal liver function tests as well. Because it works just like a statin. So, okay. B6 peroxidine, that's another one that can cause like the chelosis, like I was just saying, that same sort of look, okay, neurological disturbances. So all of the B vitamins, that's what they're used for, these types of patients. And again, glossitis, which is an inflamed tongue. A lot of B vitamin situations are patients that have malabsorption syndromes. And the best example of that is the next one, B12, cyanocobalamin. So patients that don't have what is called intrinsic factor in their GI tract, in their gut, if they don't have that, they can't utilize B12. Pernicious, and it's called pernicious anemia. So it has to be given externally, usually IM injection, like a weekly IM injection. Now, one thing I want to draw your attention to, guys, right at the top of page 833, there's a little like flow chart, and it shows you something called cyanocobalamin and then methylcobalamin. Can you see that right below that? Anybody?
Yeah.
You see it? Okay. So one of the things that we do give, a lot of people can't, because of the issue of absorption, they can't metabolize cyanocobalamin. So the other thing we can give, a lot of time I prefer to give, is called methylcobalamin. It cuts out that first step. So it gets into their body quicker and gets utilized quicker. Methylcobalamin. All right. Finally, vitamin C, ascorbic acid. What's the big disease that we don't really see much now regarding vitamin C? Scurvy, exactly, right? Used to happen to the sailors out at sea for months and months and months, and then that's why they used to give them lemons. Of all the things, really, they couldn't find oranges, lemons. Anyway. But anyway, it causes a lot of problems, right? Gingivitis, bleeding gums. But it does talk about that. In 1795, the British Navy, limes, limes. That's why Brits are called limeys. You ever heard the expression, he's a limey? That's why. That's why the Australians call the Brits limeys. In case you want to remember that. All right. So let's see, minerals really quickly. Calcium. Remember, calcium and vitamin D go together. Okay, they're a pair. And if you don't have enough calcium, obviously you could lead to something like rickets, osteoporosis. So calcium, highly important. And on page 836, I want you to be aware that there's lots of different types of calcium. We tend to give things like calcium gluconate for things like osteoporosis, but some calciums are given IV push for a patient who has some sort of cardiac dysrhythmia. So just bear in mind that there are different levels and amounts of calcium. Okay, and it does talk about that in your book, about the different types. So of course you want to be careful what type of calcium you're giving. Magnesium. Magnesium, of course, is used for many different things. It's a relaxant, right? So it can be used for constipation, but it can also be used for things like seizures. Obviously, it can be used for managing complications of pregnancy, cardiac dysrhythmias. But basically, think of what calcium does. It is a relaxant. So that's what it's trying to do, help to relax the system. And then phosphorus. Again, phosphorus is along with calcium for skeletal tissue, skeletal system and teeth. All right. Finally, zinc. I would say zinc and vitamin C go together, right? For healing. Has a great role in wound healing. All right. My suggestion is on page 840. The things I really want you to sort of draw attention to is understanding about making sure you don't give calcium too rapidly. Correct. Because you could cause cardiac irregularities, coma, seizures, sort of thing. And again, magnesium is another one as well. You want to give that slowly too. That can cause a central nervous system. Remember, it's a relaxant, so it's going to work on all of the system the same way. So it can cause CNS depression. All right. Central nervous system depressant.
And propane is the antidote for too much calcium?
Procaine?
A 1% propane?
Well, procaine is used because what it's actually saying is that the site, you have to be careful when you give calcium, you need to give it slowly because it can cause extravasation and irritation at the site. So you give procaine around there to prevent it from necrosing. That's what it's saying. It's not necessarily an antidote to calcium.
Okay.
It reduces vasospasm at the site and dilutes the effect of calcium on the tissue. Okay. So it's saying that you have to give it slowly. Let me just read this though to check that I'm right. Yeah, it's saying if it extravasates. So if calcium, basically if your IV site is not in the vein and calcium extravasates, then procaine is your antidote for that extravasation. That's what it's saying. All right. We have half an hour. Are you leaving?
Yeah.
Uh-oh, you're leaving at the best part.
I know.
Oh my goodness. All right, guys.
Can we take a break before we do it?
Uh,
Well, I gotta go anyway. I gotta go take the shirt off. It's hot in here.
if you have to leave, you have to leave, but I'm gonna keep going.
Okay, go ahead.
So, all right, have your 10-minute break. Have a 10-minute break.
What about 5 minutes? No, 10, if you pay for it, $60,000.
Well, we won't buy.
Does that make sense? I'm trying to give you information for your exam.
Please, y'all.
For next week, right?
Yeah.
Okay.
Don't you want to know a bit more than
I
that?
want to know more.
Here, we'll just walk
I just want to
out.
run to the restroom.
Go
All
ahead.
right, go
I'll
to the
just,
restroom,
what
have a
she
five-
says, I'll write
Have a
down.
5-minute break, and then I will give you information. It's like saying, here's $100. Wait. I'll just go ahead.
Are you hot? I don't know. See, I got cold. I was hot earlier. It was like that, I got cold.
I don't know why you didn't print that out. Why did the third person I talked to? I want to get that shirt on.
By the way, question, do you all have access to this book? Do I
We have it.
access to this book?
It was a little different.
Are you using this or something similar?
Yeah.
I got that, on my thing, on my Instagram account, and I haven't seen it.
Because I really like, the chapter in here regarding IV, regarding fluids and
Get
electrolytes.
that book from,
I don't have that.
Yours might look different.
That's on your eval, but I don't know if y'all actually had a
You've
look.
got it on Evo?
It's on eval, cause I just took it.
I thought I was missing out.
But that's our in-flight study book, is the same thing, right?
Chapter 8, if you've got this one, chapter 8, I really like this on fluids and electrolytes, okay?
Why we ain't get that book? Well, we got the tab.
Well, I think you have access to the
No, we
ebook.
got the.
Don't you gotta have the course ID to get into it on the phone?
No, we got that for both of that.
Oh.
But the only thing it is, person is a different edition.
That's all.
Yeah.
You don't do it here. Okay, then I'm not even worried about it.
But the fluids and
I
electrolytes
just have to all that,
chapter,
I get it freaking
I
answer
like
from
that
these
chapter
people.
in there, it's a really nice.
I need to plug my computer. Alright, so I'm not.
Okay, I'm picking a video on screen for Facebook in here.
All right, are you ready?
Yes.
Okay, let's start with this. So, you're gonna have 50 questions.
Can you please, Ms. Fletcher, I have a question for you.
Yes.
Can you please kind of spell out some of the drugs? Because I wrote the notes the last time, but the issue I had was not trying to say the drugs, I couldn't spell them properly.
Of course.
So I kind of really,
Because I was trying to decipher my own notes.
and I couldn't even understand that
Okay.
role.
All right, so. Let's look at this a little bit. Okay. Bear in mind, when somebody takes an antihypertensive medication, it's talking about human needs statement regarding antihypertensive meds. So think about this, a lot of men don't like to take antihypertensive meds because some of these antihypertensive meds can cause impotence. So that would be an example of creating a plan of care for these patients and helping them understand what the effect of an antihypertensive is, okay?
You said again, I didn't really hear you, that
It could create altered sexual function,
the antihypertensive is men.
yes.
I think that was on the head. Practice.
What type of antihypertensive causes a cough?
They have the R, ACE inhibitors.
Thank you. How do you give nitroglycerin tablets?
Under the tongue.
Every 5 minutes.
Tell me the process of how you give them.
One every 5 minutes.
One every 5 minutes.
Any, no more than 3, I think.
And then after the third one, you call the HCP provider, it depends on the rate.
Okay? I want you to review that. Because I'm hearing different things, you need to know that.
What did you say?
You need to know the process of the instructions of teaching a patient how to use sublingual nitroglycerin.
And they're going home, like teaching them,
At home,
they only
yeah.
can have one when they go home after that one, they'll go to the hospital, right?
You need to review it.
The nurse, if they're in a facility, the nurse can give free daycare if they still.
You call 911 and then you take the
But
number.
after the second one, if you still have chest pain, you call 911 and take the third.
Yeah.
Yeah, you
Right.
take the third before the ambulance.
That's what I'm telling you, review. I'm not giving you the answer. I pretty much gave you that.
She gives me
That's fine.
I read it.
I thought we couldn't give them, you can't give them three.
Review what the process is with nitroglycerin if a patient is having an angina attack. What do? Do you give 5 doses? Do you give 1 dose? Do you give 3 doses? Do you, what?
Seriously, what?
Do you give 1 and do something? What, you
You
need
give
to know what you do.
1.
And do what?
If the patient's home or if they're like,
You just give 1?
I mean, no, at first.
And then what?
And
You another one, 5 minutes later.
Right, but what are you doing? Are you assessing your patient?
Of course,
you
you
are.
are.
Yeah.
Patient, but
Okay.
you're really saying.
You need to review this. You need to review it. I'm telling you, you need to review it. All right. Adenosine, ADENOSINE, adenosine. All right. Remember, when you give that medication, what's the big thing that can happen that you would see on the cardiac monitor?
Increase in heart rate.
What did you say? Flatline.
Oh, okay.
It's called something else.
It's like the reboot.
Thank you.
Got it.
All right. A patient, let's look at this one. Let's look at what I want. All right, you should know this. What's the antidote to Coumadin? Or warfarin? Thank you. Niacin. What type of side effects?
Cholesterol.
Yeah.
Itchy.
Yeah,
Burns.
there you go.
Wait, what?
Abnormal liver enzymes.
I only have half an hour to go through all this.
What you want, the side effects of niacin? That's the question?
Yes. All right, you know that I've talked about good cholesterol. Is that LDL, HDL, triglycerides?
HDL.
H for healthy, right? That's what
Yeah.
I'm saying. Okay.
Good cholesterol.
What type of cholesterol medications cause muscle weakness?
Statins.
Mhm. Well, they are called statins, but you need to know it's called an HMG CoA reductase inhibitor.
Yeah.
Statins.
I watched that.
You need to know the actual, not just the name that covers statin, but the class.
What's the class again? HGM?
Have a look. I'm moving on. All right. What type of diuretic could cause hyperkalemia? Potassium sparing. So you need to know which one is potassium sparing.
That's the thing that I read.
I want you to know about loop diuretics.
Loop diuretic.
Loop diuretics. What statement is true about them? What is true about loop? What's good about Lasix, which is a loop diuretic?
It excretes potassium, but it gets the fluid off of you.
Right, but why would I use? in
Heart
a-
failure.
Right, but let me finish. Why would I use, like, Lasix is good because it's quick, right? It diuresis quickly. It's very rapid. All right. What would be an adverse effect of a blood transfusion? What types of signs and symptoms might you see?
Wheezing.
What did I tell you earlier?
Back pain.
Thank you. Chills and back pain.
Back pain.
See, if you actually really listen to what I'm saying in class. I give you a lot of answers. I really do. Right. No, I mean, when I'm lecturing. When I'm lecturing, I really do try and give you a lot. Thank you. Yes, that's the teacher saying, yes, I do. Yeah. All right. How many NEQs per hour do you infuse potassium?
10.
Thank you. Hypokalemia. I want you to know early signs of hypokalemia.
That's in our.
Early signs.
That's in that book right there.
You said kalemia or kalemia?
I'm sorry, hypokalemia. Now, this is the key. The key is early signs. All right? Seizures would probably be a late sign. I'm just saying. All right. What type of fluid are you going to put your packed red blood cells with? What type of fluid would you, if you're going to do a red blood cell transfusion, what type of fluid are you going to use with it? What's the only fluid you can use?
Saline.
Saline. Normal saline. Okay. This is endo now. We're going into endo. Finished. We finished cardiac, we finished electrolytes, now we're going into endo. Pituitary dwarfism. It's treated with somatropin, growth hormone. Somatropin. Somatropin. Well, let's look at this. It's an 8-year-old child. They've got pituitary dwarfism. They're treating the child with somatropin. What do you hope is going to happen? What do you hope is going to happen to the child?
Girl.
Yeah.
Well, that's right. Oh.
Increased growth.
Oh.
We hope, right? That's the
Yeah.
whole point. All right. Hypothyroidism and synthroid or levothyroxine. After a week, if the patient says she doesn't feel better, do you think it might take a little longer?
Yes. What was the drug you just said?
Levothyroxine.
Okay, levothyroxine, you spell that for me, please?
Levothyroxine. Yeah, hang on a minute. Yeah. Levothyroxine. I could have done spelling bee, apparently. Just did that one. All right. Insulin. Which way do you do it? Clear to cloudy or cloudy to clear?
Clear to cloudy.
Would you consider 47 a low blood sugar?
Yes.
So you need to know what to do.
DP.
What do you think that patient should do if their blood sugar is 47? Do DD
Drink some orange juice.
Yes, before DPD.
something.
Right.
What's the normal insulin range?
D50 is for unconscious patients, right?
Yeah, D50 like bad.
Yeah, they're out.
All right. If you've got an unconscious diabetic with that's high, or rather an unconscious patient that's hypoglycemic with their blood sugar of 34, what are you going to give them?
That's D50.
What do you do, Ms. Fletcher? Gonna be 50?
What type of insulin can only be given IV?
Regular.
Yeah. Let's see. I want you to know about tetracycline, oral tetracycline.
Alright.
Now, that was on my head.
Yeah, it will.
You need to know
TETRS.
tetracycline.
Don't give younger than 8.
What types of teaching are you going to teach the patient for oral tetracycline? Okay, somebody who's got a urine infection, I need you to know what sequence of events, how are you going to do things? Are you going to give an antibiotic before you do your cultures?
We got afterwards.
Well, I want you to know.
You want to know the UTI procedure, the UTI steps.
I want you to know the steps of what you would do if somebody's got an infection and how, meaning would you do cultures first? Would you do the medications first? What would you do?
If they have a UTI.
Yes. It doesn't even have to be UTI, it could be any infection. We'll go with UTI.
Okay.
It makes it easier.
Yeah.
All right. One of the side effects of an antibiotic, if somebody has got diarrhea, what could be a problem with a fever? In the hospital especially. If they've been on antibiotics for a few weeks, they've now got diarrhea and a fever.
C. diff.
Thank you.
What she said?
C. diff.
I'd like you to know the difference between antiseptics and disinfectants. What's the difference?
Versus anti-infective, you said?
Antiseptics versus disinfectants. There's a difference. All right. A patient with a pressure ulcer, he's got MRSA in his wound, staph. What antibiotic is probably going to be used? Staphylococcus for MRSA. Remember, it's very resistant to a lot of medications. Okay. Remember I talked about older people and quinolones. Quinolones. So what are they? Quinolones, like ciprofloxacin. Quinolone. What did I say could be a problem? I just pointed. I wasn't doing
The
like it.
wheelchairs thing, the
What did I say could be a problem?
something with TB.
You might want to look up quinolones. That's a class of antibiotics. All right. Beta blockers. Beta blockers use for angina. Patient's got a lot of other things going on. He's got diabetes and hyperthyroidism. Look up the adverse effects of these beta blockers. And look up what effect it could have on his blood sugar. Or her blood sugar. All right. Heparin therapy. What lab work are we going to do?
PPT.
Somebody who's on anticoagulants. What herbs would they avoid? What herbs would they avoid?
Ginkgo.
Aminoglycosides are a class of antibiotics.
You got it?
You don't see it on the board because these are medications, not classes. So I want you to know aminoglycosides, it's a specific class. Gentamicin is in that class. But it may not say gentamicin, it may say aminoglycosides. You need to know the classes, right?
That's the
What's the
next.
problem with gentamicin?
That's really strong. I mean. So what did you say we need to know about it? Just
Side effects.
side effects.
The toxic, remember? It could be pretty toxic. You said it's very toxic, right?
Doesn't it have a low therapeutic level?
Was
that medical?
I think we do. I think we do gentamicin. Yeah. Vancomycin. What's one of the, hang on a minute, let me look at this. Vancomycin, remember I said there's some certain things that you need to do with vancomycin. First of all, you don't infuse it fast, right? You have to infuse it slow. All right, what about if somebody's got flu and they want Tamiflu? Yeah, I'm gonna say Tamiflu. How many days do they have before they can get it?
48 hours.
42 hours. 48 hours.
Right? You need to know that. All right. If a child has taken a whole lot of pills by accident, are you going to give them Ipecac? No. You need to know what to do. Remember I pointed out that box where I said the teaching for what you do for child for poisoning.
Call poison. Call poison.
But you need to know the process. Somebody with hypothyroidism, when are you going to give them medicine to them? Hypo, yeah.
In the morning time?
No, with the pituitary gland, remember the picture of the pituitary gland? It had all of the hormones that it secreted from the anterior and all of the ones that it secreted in the posterior. And I think there's only 2 in the posterior, but I need you to know which is secreted by which.
Out of the pituitary and the posterior.
I drew a whole picture up anyway.
Yeah, it's in your book as well.
Yeah.
The picture is in your book.
I can picture.
Yeah. I used to do stuff like that.
Yeah.
Okay. Another class of medications that you need to know. Sulfonylureas. That's a diabetic medication. Okay, sulfonylurea. I want you to know the adverse effects.
You spell that?
Yeah. Sulfonylurea.
Oh, I tried.
Yeah.
That's not available. We'll work on it.
Sulfonylurea.
Nearly there. See, aren't you glad you listened to this?
Yes.
Genital herpes. The patient is given a medication for it. What's the patient teaching? Acyclovir. Acyclovir.
That's the medication?
Yeah.
You spell that?
Acyclovir. Acyclovir.
You said other patient teaching?
I think I have to make sure I got the drug, but
TB therapy.
like tuberculosis, right? You say TB, okay.
I want you to know some of the patient teaching components with TB therapy. Because these are select all that apply.
Yes, they
These
know
past few questions, you've got how many select all? 1, 2, 3, 4, 5. Uh-huh. Oh, yeah. I bumped it up.
You did, you sure did.
they don't know. They don't
Is it
think
the
it's
last
easy.
one?
To be a select stuff, right?
Select all. All right. Chemotherapy. We just talked about medications for nausea and vomiting. But in the patient teaching section on that book, you need to know what type of management, when do you give your nausea meds? Do you give your nausea meds before or after your chemo?
Before, 30 to 60 minutes
Thank you.
before.
So that's the type of thing I'm talking about. Okay. Know the side, know what happens. What are you looking for? Remember I said some of the side effects of these anti-nausea meds can cause these extrapyramidal type of effects. So you need to know some of the things. Okay? All right, now, dosage count, there's 1, 2, 3, 4. You only have 4.
I'm struggling with that, this metric.
Are you pardon?
I'm struggling with that. I tried to, you told me the analysis thing.
I need you to know how to convert pounds to kilograms. You have a drops per minute question, a mils per hour question, just one way you need to convert from pounds to kilograms, and just one that's like how many mils, but you need to know again how many, you need to know about your kilograms, converting pounds to kilograms. Okay.
So then, could you also just, like, okay, so the chapters, it's one on cardiac, it's on electrolytes, it's on.
Yeah, so you've got a cardiac, but of course there's different sections like I told you.
Right, but I just wanna read through all of it, so.
Cardiac, there's electrolytes,
Cardiac.
so there's fluids and electrolytes, right? Cardiac section. There's endocrine, which includes not just things like hypothyroidism, but insulin. Okay. There's your anticoagulants, TB, antibiotics. So that's why I went over it, because there's a lot of different sections.
I'm okay with that, I just wanted to cover all of it. And then the
Okay.
nausea and vomiting one, right?
Yes, nausea and vomiting.
Yeah, because there was a lot of antibiotics on the history, on mine. It was a lot.
Really?
It was about like 3 or 4, maybe 5.
I have more med surg and labor and delivery.
Yeah, but it wasn't asking you about labor and delivery, it's probably asking you about magnesium or something.
No, that's not labor and delivery, yeah.
If you got a drug in the contraindication
Yeah.
Well, is it talking about misoprostol?
Okay.
Yeah, was it talking about that one?
Yeah.
Yes.
It was talking about that test and
Tetracycline. So it really was talking about what medications, be aware of the red flag type of.
Yeah, we took most on the safety of the drug, you know?
Yeah, it was, yeah.
She got kicked off of that, so I put her on speaker.
Okay, okay. All right, well, I'm gonna